you testified about the issues that he had, that he was a very sick man. Do you recall that?
Yes.
And that included septic shock.
Yes.
He had issues with his kidney.
Yes.
And he also had lung issues, correct?
Yes.
Now, you mentioned that he had CPR. He, in fact, had 5 cardiac arrests. Isn't that correct?
That is correct.
So, the 5 cardiac arrests, that's a lot of pumping down on Mr. Maletti. Wouldn't that be accurate?
Yes. Yes.
And when you give CPR, it's often common to get to crack some ribs, right?
In my experience, when I gave CPR, ribs were broken.
And after 4 cardiac arrests, fair to say that's something you took into consideration?
Absolutely.
And Mr. Maletti had 4 organ failures, correct?
Yeah, he was in we call it MODS, multi-organ dysfunction.
Tell us what that means.
Yeah, so similar to the explanation earlier, lack of blood flow when you're dead because the person is giving CPR is basically acting like a heart. We're doing the pumping. Everything in between your head to your toes goes with suboptimal flow. So you're not getting blood flow and, more importantly, oxygen to important areas like kidneys, your bowels, your limbs, your heart, your lungs, your brain. All of those things can't go very long without oxygen or blood. So time is of the essence, but this gentleman had respiratory failure, hence the need for an intubation and FiO2. He had shocked liver, meaning that his liver enzymes were elevated from a lack of blood flow. He had an acute kidney injury, which is essentially on its way to renal failure. We just use the term acute kidney injury. We lost perfusion in an entire limb, the left lower leg. And then his cardiovascular system has failed. He was on 3 vasopressors. So 3 different types of, in some ways, that adrenaline-like medication.
And you have given the analogy of vasopressors being like jet fuel. Is that correct?
Yeah, yes, yes.
Okay. And that's basically a fuel to keep the heart going and the blood pressure going.
Yes, it's artificially keeping the heart pumping and keeping the vessels tightened up to raise blood pressure.
Now, what effect does multi-system organ failure have on the distribution of meds when it's given?
Okay, wait, I think that's a little beyond his ability.
I'll ask it.
You don't have a foundation for that question.
In your education and experience, do you learn about, at the time of this occurring, did you know and learn about how, when you have multi-system organ failure, meds are distributed through the body?
Again, the same problem.
Did you, I'll try one last time after that. When giving, you've given a lot of meds in the course of your duties as a nurse in the ICU, correct?
Yes.
And are you trained to look at the physiology of the patient as it relates to how much meds a person is supposed to get or what effect they might have on the patient?
Yes.
Given that, does multiple organ failure play a role in that?
Start the same problem.
That's okay, Judge, I'll move on. Back to the oxygen
Okay.
issue. Mr. Maletti was on 100% oxygen at the time of his extubation, correct?
Yes.
Okay, and you said something during direct examination about us being on 20% oxygen here in this room, right?
21, yes.
21, okay. If someone is breathing, or is the reason why Mr. Maletti was on the 100% oxygen is because that was the setting required for his illnesses? For his illness?
Yes. The pathophysiology of what killed him 4 times necessitated the need for higher levels.
Let's strike that.
Um,
Ladies, you disregard after the answering the yes or no, everything else you disregard.
So it was set because of his condition at 100?
Yes,
Okay. Now, you mentioned that he was on,
I'm sorry?
I would object, move to strike.
What, the last question, overruled?
now during direct examination, you were shown a series of records for Mr. Maletti. You recall that?
yes.
Okay. What do you call it?
Just, he is count, what is count? I just called it the medical records from count 4, from joint exhibit 4.
Joint Exhibit 4,
Identify what it's labeled.
you were previously shown this. Let's see if I can zoom out. Okay, here we go.
It'll do it for you if you just hold it still for a second.
Got it. And do you see at 2015 on the 5th of December, you noted that he was on 100% oxygen. Is that correct?
That's correct.
All right. Now, what's that going to do to a person once they get taken off of 100% oxygen and the room only has 20 when you need 100 to breathe?
Objection.
Sustained.
When you were asked on direct examination about, or you spoke of the oxygen levels, why did you bring that up?
That is a good indicator of how sick and injured a person's lungs are.
Is it an indicator of how long they may breathe after being taken off the ventilator?
Objection, Your Honor.
Sustained.
Based on your training and experience and what you've seen during palliative extubations, is it an indicator of how long a person will be able to breathe for once taken off the ventilator?
Objection, Your Honor. He doesn't have this knowledge.
Sustained.
Now, sir, you mentioned, well, the prosecutor had asked you in reference to the order for the fentanyl. He mentioned to you, do you recall that your testimony that it was a verbal order?
It was a verbal order.
Okay, I'm showing you Joint Exhibit 4, page 168 through 169. Do you see that, sir?
Yes.
And do you see the patient name there? Is Danny Millette?
Yes.
And I'm showing you on the bottom an action time at 21:23 on the 5th. That's at the time of the ordering of these meds, correct?
Yes.
And it's specifically the fentanyl, the 100 microgram, I'm sorry, the 1,000 micrograms?
Yes.
Do you see what it says here?
It says entered and electronically signed by Dr. William Husel.
So does that indicate to you that it was a written order by Dr. Husel?
Yes.
And I guess you also just entered one in verbally, is that correct? You have also entered one in, correct?
Yes.
Is that maybe where the confusion lies?
It could be.
Okay. Now I want to talk to you about when you spoke with Danny Millette's family. You testified under direct examination that, and I wrote this down, discussed all of the things we were going to do. Do you recall saying that under direct examination?
I recall that.
tell us about all of the things that you discussed.
Yeah. So on top of the prognosis with him that we detailed earlier, we talked about how we're going to turn off the IV pumps, which contain the vasopressors. We talked about how we were going to discontinue the ventilatory tube. We were going to take out the endotracheal tube, put a little bit of nasal cannula on him if he needed it, and we were going to give him pain medication, that would help him be comfortable and pass naturally as a result of his underlying illness.
Did you discuss with the family the potential side effects of the medication?
They were discussed.
Okay. And did you feel that the family, did you feel that the family was well informed by both you and Dr. Husel?
Yes.
Okay. And that included being well informed of the potential side effects of fentanyl?
I think so, yes.
Now, I'd like to move to Mr. Allen. Oh, before I do,
Okay.
Mr. Maletti was on 3 vasopressors, correct?
Yes.
And he was receiving the maximum dose of those vasopressors, correct?
In my best recollection, it was very high, yes.
And despite being on 100% oxygen and 3 vasopressors, he was still actively dying on this life support.
Yes.
You told the jury during direct examination that vasopressors act very quickly. Is that correct?
Yes.
Okay. How quickly, in your training and experience, do you see when you turn off vasopressors that they stop working?
Objection, Your Honor.
I'll permit the question in that format. In your observations
Yeah.
as a nurse,
Um,
that's what he wants to know.
about 1 minute, 30 seconds to 1 minute.
So in 30 seconds to 1 minute, the jet fuel that's keeping him alive is turned off. Is that correct?
Well, it's turned off and then it begins to lose its effectiveness in about 30 seconds to 1 minute.
Now, let's discuss Mr. Allen.
Okay.
You discussed on direct examination, again, that this was also a very sick man.
Yes.
He had COPD,
Correct.
and that affects the lungs, correct?
Yeah. Yes.
And what does COPD stand for?
Chronic obstructive pulmonary disorder, maybe? I'm basically, it's an issue of the lungs, and it can be secondary to smoking or just the natural aging process as we get older.
Okay, and Mr. Allen was also on vasopressors,
That is correct.
and he also suffered from coronary artery disease.
Yes.
So that's, his lungs are not well, so is his heart. Is that correct?
Yes.
Now, you mentioned that Mr. Allen was I guess in your direct testimony, you mentioned that Mr. Allen was at the ICU and then he was returned to the floor. Do you recall that?
Yes.
And then you also testified that while on the floor, they had trouble reaching the doctor. Do you remember that testimony in direct?
Yes.
Okay. And that he was paged multiple times?
Yes.
No objections? Okay. I'm showing you Joint Exhibit 8, page, it looks like 846.
I see that.
Okay. Now, you mentioned that Dr. Husel is always available, or very available.
Yes, he would freely walk around the unit and be available to us, the
Okay.
nurses.
And in this note that you testified under direct, you see the nursing note, I have paged Dr. Manjan at least 10 times and he has not called me back. Operator paged him and operator called me back and said Dr. Manjan hung up and hasn't answered.
Yes,
Okay, and then, further down on the note, it says, Dr. Manjan called back after several pages, and this nurse reviewed vitals and everything that has went on over the last few hours, notified that son John would like to speak with him. Physician will try and call, but it will be a few hours. Notified of blood pressure now, and the ICU orders need to be discontinued and monitors needed. Do you see that?
I do.
Okay. It was at this point, after not receiving the proper care, that made Mr. Allen return back to the ICU, right?
Yes,
So basically, Mr. Allen had a procedure,
twice.
okay, and after the procedure, he was doing okay in the ICU.
He was doing okay enough to be transferred out.
They transferred him out, and his blood pressure dropped,
Yes,
and they couldn't get a hold of the doctor.
that's correct.
And when they did get a hold of the doctor, he gave him some salt water and thought his pharmacology was probably as a result of the surgery.
Yes,
Okay. And then he ultimately ended up having a cardiac arrest in the morning.
yeah, he died.
Oh, I mean in the ICU, yes, in the ICU that morning, correct?
Yes,
And it was later when you came on the night shift and had to take care of him. Is that correct?
yes,
Now, you mentioned that this gentleman was beyond sick and he was coughing up blood. Do you recall that?
and it led to aspiration pneumonia, yes.
Okay. And you also testified that his vent settings required more support.
Yeah, he had what we call an ARDS ventilator setting.
What does that mean to us lay folks?
Acute respiratory distress syndrome. So, and I would have known this at the
Okay,
time.
answer
Yeah.
the question.
Sorry, sir.
Okay.
We've been through this once.
Sure, I was just,
You were just repeating it. I understand.
I was going to say I was just transitioning, but
This is attorney humor, ladies and gentlemen of the jury.
having said that, you mentioned, well, Mr. Allen was also on 100% oxygen, correct?
Yes,
And also on vasopressors, correct?
yes,
Now, you were asked about paralytics at this point. Mr. Allen was not on any paralytics, correct?
nothing that on my, no, he was not on a continuous infusion of paralytic.
In fact, you didn't see anything in the record, or you, during your care, never gave him any paralytics.
To my knowledge, no.
Okay. And you said that when you were approached, that you were sitting at the nurse's station, and the family approached you.
Yes,
And it was, when the family approached you, it was with the intent to withdraw care, is that correct?
yes, that's what I recall.
And it was at that point that, that's not something you could do, you needed to call Dr. Husel to hear the family express their wishes, correct?
Yeah, I could not, it's out of my scope of practice to make that change, so I called the physician to the bedside.
And it is at this time that you also discussed the withdrawal of care, including the palliative withdrawal, correct?
Yes,
And you testified on direct that the patient was not stable, correct?
correct.
Okay. And you didn't discuss on direct examination, let's see. And you didn't discuss that conversation with the parent, with the family, excuse me, of Mr. Allen. I'd like to get into that a little bit. Was everything discussed with Mr. Allen's head?
Yes,
And including the potential side effects of the fentanyl?
yeah, yes,
And was it your belief that they had all the information they needed?
yes,
And if Dr. Husel had not given all of the information needed,
Objection, Your Honor.
would you have,
Sustained.
okay? Is it your custom and practice to ensure, whenever you're doing a palliative withdrawal, that the family has all the information they need?
yes,
And did you feel, in Mr. Allen's case, that they had all the information?
I do.
Now, you had noted that, and you're going to have to forgive me, sometimes I can't even read my own notes. It says that he was drawing and grimacing?
Withdrawing.
Oh, withdrawing, okay. Withdrawing and grimacing, okay. And do you recognize grimacing and withdrawing as a symptom of pain?
Yes,
Okay. And however, it was pointed out that there were no, what was the pain noted for Mr. Allen?
I believe it was noted as a 0.
Okay. And is that because things move quickly in the ICU?
Yes,
And you sometimes
Okay,
make
hold on,
errors?
I'm lost here. You gave it a 0 because things move quickly in the ICU. Is that how I understood your testimony?
oh, no, I gave it a 0 because at the time of that particular assessment, I did not appreciate the presence of pain.
Okay.
Let me clarify, I think I asked it poorly, Judge. So, if things are happening quickly in the ICU, do you always have time to chart right then and there?
I do not.
And is it fair to say that while you may try your best, sometimes the records don't give the full picture of what's going on?
Yes,
And in this situation, do you think that's the case with Mr. Allen?
I do.
All right, now I'd like to move to Mr. Timmons. Now, Mr. Timmons, as we've already covered, was an overdose patient.
He was a patient who presented secondary to an overdose, yes.
And he, of course, had heart issues.
Yes,
And rather than go over all of his medical issues, fair to say he was extremely sick.
yes,
And when you arrived, you said that you saw the crash cart outside of his room.
that's correct.
And before you can get a complete update as to what was going on in his condition, his blood pressure started dropping into the 60s.
That's correct.
Now, it's at that time that in an emergency situation, you summoned Dr. Husel.
I told somebody to get him, yes.
Okay. Well, you summoned, you got
Yeah,
somebody to get him.
yeah,
Okay, so he comes running in, right?
yes,
And when he gets there, Mr. Timmons is actively dying, correct?
yes,
And he doesn't order 1,000 mics of fentanyl and say, all right, let's just end this right now, right?
no, that didn't happen.
In fact, tell the ladies and gentlemen of the jury, well, you kind of went into some of it during your direct, and I don't want to have to repeat all of that, but there were multiple life-saving measures employed at this time, right?
Yes,
In fact, one could classify it as numerous.
I would agree to that.
Would you agree that Dr. Husel, in his interventions here, did everything he possibly could to save Mr. Timmons' life at this point?
Yes,
Objection, Your Honor.
Okay, sustained. Ladies and gentlemen, disregard the last answer and question.
Okay. He ordered sodium bicarbonate, correct?
Yes,
To correct the acidosis.
yes,
He ordered glucose, correct?
yes.
He ordered calcium to increase his blood pressure.
And to stabilize the cardiac membrane, yes.
He then ordered epinephrine, which is a vasopressor, correct?
Yes.
To increase his blood pressure.
And help the heart pump, yes.
He ordered hydrocortisone to increase the blood pressure, basically to help the vasopressors perform better.
Yes,
He ordered vancomycin.
vancomycin,
Yes. A second antibiotic to help fight infections.
yes.
Meropenem, a third antibiotic to address the infection.
Meropenem, yes.
Yes. Then he ordered norepinephrine.
Yeah, that's another name for Levophed, yes,
Okay, and that's also to keep the heart beating and increase his blood pressure.
yes,
He then ordered insulin.
yes,
He then ordered another dose of calcium to increase the blood pressure.
yes,
Glucose, again,
yes,
and another sodium bicarbonate.
correct.
And then 1 hour before withdrawing care, he then maxed out the vasopressors.
That's correct.
Have you ever been in a situation where a patient was dying like that, actively dying at such a high rate of, at such a high rate of speed where you had to institute so many life-saving measures prior to Mr. Timmons?
There, yes,
Okay. And would you say this was right up there with that?
what do you mean by that? Right up there.
Sustained.
I'll withdraw the question. Now, you testified that the brother, Mr. Timmons' brother, was it Lynn?
Yes,
Okay. Lynn had approached you and told you, it looks like we're going to be able to get through the night, correct?
that's what he said.
And what exactly did you say in response to that?
I said, I don't even think about it that way. I can't say that. I'm trying to get through the next 30 minutes to 1 hour.
Did you at that time instruct him not to leave the hospital?
Yes,
Did he leave?
yes.
And then how long before you felt you had to call him back?
Shortly after the second time that the patient kind of had a similar presentation to the beginning.
And after going up on the vasopressors, and when he came back, did you give him an update as to what was going on?
Yes,
And as the nurse addressing a patient, who has more contact with the patient? Is it the nurse or the doctor?
I mean, I deal with the patient more than the doctor.
And who has more contact with the patient's
Well,
family?
hold on. Your question was with the family? He said the patient.
I'm asking both.
Okay, well, that isn't the way it come across to me, so let's rephrase it.
Sure, let me rephrase it. Who has more contact with the patient? The nurse or the doctor?
Nurses,
Who has more contact with the patient's family? The nurse or the doctor?
nurses.
Okay, and when he came back, when Lynn came back, you gave him all of the information that, I guess you updated him with the care?
Yes,
And what did he say to you in response after giving him an update?
it is then that he made the decision that he wanted to withdraw care. He said that his brother wouldn't want to live this way, to take all the SHIT away, and that's whenever I went and got Dr. Husel.
Okay, and it's at this time that Dr. Husel came and you guys discussed the palliative withdrawal?
With the patient, yes. Or with the patient's family, I'm sorry, yes.
Brother, right?
Yes.
And did you have a thorough discussion with the brother?
I believe so, yes.
Was he advised of the potential side effects of fentanyl?
Not specifically fentanyl, just he was advised of the side effects of the pain medication we were going to give.
Okay. And that would include respiratory depression, potential respiratory depression?
Yes.
Okay. So we're clear on we've been hearing a lot of terminology being thrown about as it relates to respiratory. Tell the ladies and gentlemen of the jury what respiratory distress means.
Yeah. To me, respiratory distress would mean that the patient is actively fighting to breathe, fighting to move air in and out of their lungs. It's usually it's something that you see. It's something that you can visually see where they're sort of sometimes tripoded over, huffing and puffing, kind of the muscles in their neck and the muscles in their sides are kind of working hard. It's an exhausting process it could be an exhausting process for the patient to remain in respiratory distress.
Now, tell the ladies and gentlemen of the jury what respiratory depression means.
Yeah, respiratory depression would be a reduction in the frequency in which you breathe.
And this is based upon your experiences and your dealings.
Yes.
I'll preface it, Judge, that way. So, based on your experience as an ICU nurse, sometimes the opioids are given to address the respiratory distress.
Yes.
Okay. And that is accomplished by respiratory depression sometimes, correct?
Yes.
Okay. And then there's respiratory arrest. Tell us what that means.
In my experience, that is the complete cessation, the complete inability to breathe. You can't move air in, which leads to a heart attack, and you die.
Okay. So those are all three different things, correct?
To me, yes.
Okay. Now, you stated that after extubating Mr. Timmons, that at some point the brother, Lynn, came running. Is that correct?
Yes.
And what exactly did he say?
He's in pain. He's in pain. Somebody come. He's in pain.
Now, I wrote down that you said, help, help, somebody do something. Did he say that?
He said, help. He's in pain. He's in pain. Somebody do something.
And you testified that he was gray and blue?
I guess I'll just say discolored, just because that's subjective.
Okay. And are you familiar with the phrase bad death?
Yes.
And is that what you believe you were seeing with Mr. Timmons?
Sustained. Ladies and gentlemen, disregard the question and the answer.
What is a bad death, sir?
Sustained.
Based on your training and experience.
Sustained. This is our discussion the other day.
Okay, I'll move on. Now, after this is when Dr. Husel ordered more pain meds, correct?
After the brother came out of the room.
And
Yes.
this was to address the symptoms that Mr. Timmons was experiencing at that point in time, correct?
The second dose, yes.
Okay. And that is when you needed the assistance from other nurses?
There were other nurses helping, but I was using their assistance far before that.
And after getting all of this medication from the Pyxis machine, you felt it was prudent to, at this point, call the pharmacy to let them know what was going on, correct?
I called the pharmacist, yes.
And you testified in direct that you spoke with Talon Schroyer,
Yes,
and you're familiar with Talon Schroyer's voice?
yes.
Okay. And you testified in direct that he brought up Mr. Timmons' chart at the time and saw the meds that he was being given?
Yes, we were simultaneously looking at the MAR.
And it is at this time that you told Mr. Talon-Schroyer the fact that Mr. Timmons had a history with a drug history, correct?
I said he had a tolerance, drug tolerance.
And speaking of tolerance, you're aware that Mr. Timmons was given 14,000 micrograms just a few hours earlier for that surgery, correct? Or a day before?
I'm aware that he received 14,000 micrograms of fentanyl.
And that's not including the 25 microgram drip that you mentioned during direct examination?
That is my understanding,
And
yes.
that's also not including the 175 microgram drip that you discussed in direct examination, correct?
Yeah, yes.
But while pointing out those two, do you recall testifying at all on direct examination about the 14,000?
I'm not sure I was asked that.
Okay. You don't recall that though, right?
You've asked it twice now.
Again, what you were seeing by Mr. Timmons appeared to you, based on your training and experience, to be painful, correct?
Yes.
And Miss Emma Young had marked it at 0, correct, the pain score?
I testified to that, yeah.
And again, this is another example of, would you agree that this is another example of the records not telling the true and accurate picture, correct?
Wait a minute. Let's go sidebar. I haven't done it all day, guys. I'm trying to be better. We can get there. Okay. I heard that. Hi, guys. We gotta let the court reporter get caught up to us. She has to get caught up to us. You guys can't hear me? Whoa. Damn. Can you hear me now? Okay. We have to wait for the court reporter to catch up to us. Okay, you ready there, Madam Court Reporter?
Yes, sir.
Mr. Baez.
Mr. Deemer, I think my last question to you was, and this is another example where the records don't always tell the complete and total picture, right?
Yes.
And in fact, are you familiar with the expression, "there's nothing like being at bedside"?
Yes,
Do you agree with that statement?
100%.
In fact, nowhere in the records does it say that that Mr. Timmons was foaming, correct?
That's correct.
And nowhere in the records does it say that he was having these agonal breathing, correct?
I don't believe so, no.
And nowhere in the records does it say that he was turning gray or blue.
No, it doesn't.
And just so I'm clear, whenever you are doing a palliative withdrawal, some of the things that you look for or you're concerned about based on your training experiences, one is pain, right?
Yes.
The other one is suffering, correct?
Yes.
And that could be the patient suffering or the family suffering as they're witnessing their loved one die.
Yes.
And then the other one is, of course, respiratory distress.
Yes.
Now, that's not an all-inclusive list, right?
It's not.
Okay. Now, I'd like to show you the medication order set that's been shown in this case a couple of times, and that's Defendant's Exhibit MCD 16. Do you see that?
I see this.
Okay. And it's specifically for palliative withdrawals?
Yes.
Okay. And then this one is the one that was the policy, the effective
Counselor,
date.
where are we going with this?
I'm-
He's not an ER doctor, he was a nurse.
I'm aware of that, Judge, but he is
So
familiar.
why are you showing this to him?
I have a couple of questions about it. He's familiar with these. I'm aware of him being familiar with these.
So? Help me understand.
Sure.
Ask your questions, make your record,
Okay.
and we'll see where it goes.
All right, I'm going to start with 15. This is an order set that was effective between 2010 and 2016. Do you see that?
Yes.
Okay. And under medications,
Your Honor, I
Okay.
would object as to foundation.
Sustained. He wasn't even there during that period of time.
all right, I'll try and see if I can discuss it another way, Judge.
I believe that was his
Oh, okay,
testimony.
you're right, there's another one, sorry. Okay, from 16 to 19, you were currently working there, correct?
I was employed there, yes.
Okay. And under medications of this order set, the very first thing that's written here as a guide for withdrawing terminal patients,
I would object as to foundation at this point. He doesn't-
Yeah, a little bit more foundation, I agree. Okay, we're both talking, my fault. He objected. Speak up. Go ahead and get your objection on the record.
Foundation.
Okay, I'll sustain, let's lay some foundation with
Sure.
it.
Mr. Deemer, you're aware of this order set policy, correct? Or guide, I should say.
I'm aware that that doctors can use an order set for this, for pulling the tubes.
And in fact, you brought this to the attention of the prosecution, did you not?
Objection, Your Honor.
What's relevant?
My
Sustained.
last question would be relevant, Judge.
Okay,
We'll
well,
tie it
it's
together.
sustained now. Tie it up then, real
Okay,
quick.
sure. Do you see where it says, after withdrawing of terminal patients from ventilator support, principle of double effect, as a note?
Okay, that doesn't tie it up.
Sir, are you aware of any guides or policies that address the issue of the principle of double effect?
Objection.
Sustained.
Can we go sidebar?
Yeah, absolutely.
Sorry.
Hi, guys. David? They definitely. Okay, you ready there? You ready, Sam? Okay, ladies and gentlemen, the objection was sustained or disregard the last question.
May I have just a moment, Judge? I want to.
You may. For some reason, that clock now has a glare on it. I can't see it as well as I did before.
Okay, do you have that? Sometimes the boss instructs me what to ask. So. Let me ask you this, Mr. Deemer. Do doctors wear the same color scrubs as nurses? Am while you were working there?
No.
Okay, what color do nurses wear?
We wear blue.
Okay. And what color do doctors wear?
Sometimes they wear street clothes. Most of the time they wear a white coat.
Okay. Are there scrubs dark blue?
I'm not sure.
But the uniforms or scrubs that are worn are clearly distinguishable between a nurse and a doctor, correct?
Yes.
Okay. And you're currently working as a nurse where?
Objection, Your Honor. Hey, Husel.
Oh, okay.
Strike the last question then?
Yes, let me ask you this, ask this way, I apologize. What position do you hold currently?
I am a certified registered nurse anesthetist.
Okay. And what does that entail exactly?
It entails earning my master's degree in studying anesthesia, which I did. And now I am still a nurse, but I am now licensed to administer anesthesia. And what that entails, my job duties are to assess a patient, formulate a plan for the patient's surgery, corroborate with the attending physician, the anesthesiologist, my plan and his plan, provide the anesthesia, pain medicine, all of the things necessary for them to have a safe surgery, successfully put a breathing tube in most of the time, and then most importantly, wake them up.
And this is something you've been studying for quite some time, including while you were at Mount Carmel, correct?
Yes.
I have no further questions.
Redirect?
Good afternoon, Mr. Deemer. Let's go back to where Mr. Bias started with the question about where you learned 1,000 micrograms of fentanyl was an appropriate dose. Do you recall that question?
Yes.
Okay. And he referred you to a prior sworn statement at a previous hearing?
Yes.
Okay. And do you recall the scope of where you said you learned that in that previous hearing? The scope of where this was an established practice?
I'm not sure I understand. I'm sorry.
He's asking you, when you answered that question earlier in the deposition,
Yes.
what experiences was that based upon?
Oh,
As your nurse or as your new title?
No, I wasn't
No?
asking that, no.
Okay, I'm sorry.
Yeah, this is all about back in 2017 when this is going
Okay,
on.
go ahead and then ask the question again.
All right. Was this a hospital-wide thing, or was this the unit, meaning the Mount Carmel ICU at nighttime you were referring to, where this was an established practice?
it was, I only know the ICU, so I was speaking to the ICU.
Okay. So this was the established practice of the ICU at night, because that's the only thing you ever worked, right?
Yeah, yes.
Okay. And that's where you learned 1,000 mics was okay.
Yes.
And this would have been in 2016, 2017 when you started.
Yes.
And you know when Dr. Husel started.
Do I know when he started?
Right.
I think the previous year, 2015.
Okay. We heard testimony 2013. Does that sound right based on your prior relationship?
Sustain, it's outside the scope.
Okay. But who's teaching the nurses that work the nighttime ICU?
Objection. Calls for speculation.
Okay. Rephrase the question.
Who is teaching the nurses based on your observations? Who's the teaching person there?
Objection.
Finish the question.
Who's the teaching person there on the nighttime ICU during your tenure there?
Okay.
Objection.
I'll permit the overruled. You can answer?
It's many people.
Who's the main one?
I can't answer that. I mean,
Objection, Judge.
Well, if you can't answer it, I think that's the answer. Did you see Dr. Husel readily teaching everybody? Was that your testimony?
yes,
Nurses,
yes,
the people that stock the shelves,
techs, yes,
techs, right?
yes.
And were there any other doctors on shift with him at that, when he worked?
Yes.
I mean, in the ICU.
Oh, no.
All right. Actively dying equals an emergency. Do you remember that line of questioning?
I do.
And who trained you in that?
I'm not sure I've ever been trained. I don't think anybody ever has specifically said if somebody's actively dying, that's an emergency. I think that is, my recognition of those three emergencies was my independent assessment of the situation.
You talked about your interaction with the Allen family, or Mr. Allen's family.
I did.
Do you recall the family approaching you and asking you, can we wait 20 minutes until midnight because that's his birthday that night?
Not that I remember.
Based on your review of the medical records, would there have been an issue of waiting 20 minutes so he could have turned 81?
Objection, Judge.
Can you answer it?
Can you just, can you tell me again? I forget what you asked.
Based on your review and understanding of the medical records in 2018,
Yeah.
we've gone through them extensively, you've testified about a lot of details on them.
Yes.
Would there have been an issue of waiting 20 minutes to do the palliative extubation and the administration of those medications?
I'm not sure. Things change in the ICU.
Can you describe the person, looking back in your mind, who you say approached you about the withdrawal of life-sustaining care?
I don't remember.
You don't remember anything, gender, age, looks,
No.
in any way?
I only remember that interaction based off of my charting, and that is when a family,
That's not mine. Go ahead, I'm sorry. You don't remember?
no, I don't remember if it was a man or a woman.
All right. Regarding Mr. Millett, remember the questions on cross about the toe being amputated and his bypass surgery, the vascular bypass surgery done on his leg?
Yes.
That was not during this hospitalization, was it?
That was correct. That's correct.
That was from a previous hospitalization back in November, which is not too distant in the past, but a week or two before.
That's correct.
Right. And it was a question to you about the 5 cardiac arrests, and then it was changed to 4 cardiac arrests. Do you know actually how many times he coded in the ER?
Numerous.
Okay. You don't know if it was 3, 4, 5?
I can't, the records are blurring together a little bit at this point.
Okay. And at the point that you're seeing Mr. Millett that night, would you have scoured those records to see those things and to take that into account in the dosing of Dr. Husel?
How many times he coded? That would have been something I had in the back of my mind. Typically for me, in my practice, 1 code is enough with the with the person doing CPR to break ribs. So anything after 1 kind of blurs together for me.
And let's be fair, your practice is the doctor gives you a prescription and you fill that prescription, right?
Objection.
I'll permit it. It's transitional.
He gives an order and I satisfy that order if appropriate.
Okay. So you are not the prescribing authority.
I have no prescriptive authority.
And you still don't have prescriptive authority?
I do now in my current role.
Okay, I meant throughout your course I meant when you're seeing Mr. Millett or Mr. Allen, et cetera.
Correct. I would need an order.
So are you the one making these decisions about the dose, the type, and the timing, the way this medicine is going to be delivered, et cetera, during this?
I'm not the person who, signs off, but it is a care team directed decision.
And as you stated, as a nurse, as part of that care team, you have the ability to, in your words, clarify with the prescribing doctor.
And pharmacists and other nurses should you need to.
And in these cases, you clarified each time these orders with Dr. Husel.
All 3 times.
And in 2 of those times, you clarified these orders with pharmacy, or at least you recall seeing pharmacy the first time, Greg White,
Yeah. Yes.
and you do recall a conversation with Taylor Schroyer.
Yes.
All right. Did you testify at a previous hearing that in fact it was your understanding Greg White had authorized prior to administration of those medications on Mr. Millett?
I'm not sure.
You don't recall testifying to that?
I recall having depositions, but I don't recall that specific statement.
Do you recall testifying then that you later found out that that was not accurate, that Dr. Greg White had not authorized?
Objection.
Do you remember having that during the testimony?
Are you talking about learning after that he found, or learning after the fact that he didn't verify that, or was that what you're asking me?
Yes.
I said that somewhere, yeah.
You talk about how quickly vasopressors act and how quickly within 30 seconds to 1 minute they stop acting, right?
Well, they begin to decline in their action.
Is it your testimony, did you mean to say on cross-examination that it was the care of Dr. Magin that caused Mr. Allen to go back into the ICU? Is that what you believe the medical records show, or the lack of care of Dr. Magin?
I can't specifically say it's Dr. Mangin's fault, but I came from an environment where if I needed a doctor, he was readily available. So was Dr. Hagras. So when I hear about a patient who's rapidly declining and there's orders or there's progress notes that say they can't get a hold of them, I think a delay in care could have led to some harm there.
That would be speculation on your part regarding the care Dr. Magin gave him?
Sure, or didn't give him, yeah, sure.
You were not present for any of that?
I was not there, no.
Okay. However, it did reference the family and how involved they were and how insistent they were about the care Mr. Allen was receiving.
In terms of the son wanting to speak, or that person, that family member wanting to speak with him, yeah, that's correct, that was written.
And is it your memory that the entire Allen family and everyone that was there was that persistent about the care Mr. Allen received?
Objection. Leading.
I'll permit it.
I wasn't in the room for that. I don't know.
You don't recall the Allen family being there and questioning and being an advocate for Mr. Allen?
You mean on my shift?
Yeah.
Oh, okay. Yeah, they were involved in his care.
As is evident by the note regarding Dr. Magin.
Well, and they were in the room, obviously, and had to be updated, which led to them coming out and finding me, voicing their desire to withdraw care.
All right. And that's your memory of how it happened, but you can't tell this jury about anything about that person looking back in your mind's eye.
No, I just can recall being approached by a family member.
All right, let's talk about the family member on Mr. Timmons.
Yes.
You know his name, you remember him, Lynn, right?
Yes.
All right. Do you recall calling Lynn multiple times during the night after he had gone home and asking him to change his brother's status to DNR-CC?
I recall calling him, but I never would have said, hey, you need to come in here and change this code status. That would not be something I said.
Do you remember calling him multiple times?
I remember calling him, yes.
And once again, multiple times, like you remember calling him, was it once, twice, three?
Oh, I'm not sure the number.
Do you recall that Mr. Timmons had a son that was driving up from North Carolina?
No.
Objection, Judge. It's not Mr. Timmons. Mr. Hayes.
It's not? Oh, sorry. Oh, well, there you go. Sorry. Please, if I could, I will withdraw that question.
Withdraw the question, ask
My
a new
mistake.
one.
I
Okay.
apologize. You were asked questions about respiratory depression. You recall that?
Yes.
And you recall testifying on cross-examination regarding your knowledge of respiratory depression at the time of these palliative withdrawals?
Yeah, I answered that.
Okay. So you're aware of the phenomenon, correct?
What phenomenon?
Respiratory depression.
Yes,
You understand what it is medically.
I believe so.
That was your testimony. But you were not aware of the package inserts on midazolam and/or fentanyl regarding the known effects of respiratory depression.
Objection. Leading.
Okay, he's asked, I permit the question, but I haven't heard it all, so finish up your question and I'll rule.
All right. Were you aware of, but you were unaware, or were you aware of the known respiratory depression effects of midazolam and fentanyl individually?
Okay, sustained.
Were you aware of respiratory depression being a side effect of fentanyl at the time?
Yes,
Were you aware of respiratory depression being a side effect of midazolam at the time?
yes,
Were you aware of the synergistic effect of those two drugs when given at the same time?
Objection.
As to his awareness, I'll permit it.
At
Fear.
that time.
At that time?
Yeah, that's what he said.
it was just that, it was a theoretical concept that was briefly covered in training.
Okay. And what training are you talking about? Was this training that you received during school or training you received from Dr. Husel?
My answer there was referring to my clinical, so that would have been my education, my school.
So did Dr. Husel ever talk to you about the synergistic effects of fentanyl and midazolam being used together causing respiratory depression?
I don't think so.
Regarding the death of Mr. Timmons, the two doses, the 1,000 micrograms and the, how much midazolam did he get?
The first time 10,
Okay. Those are given at what time did the MAR indicate?
I wouldn't be comfortable saying. I could see it, and that would help me.
Was it 3 p.m.? Does that help? 3 a.m., excuse me? And then I can get them out again. Do you recall that being,
Roughly, approximately,
all right?
it was after midnight.
And then, do you recall testifying about the 5 minutes?
Yes.
later? So the time frame we're talking about was within 5 minutes. You say he came running out and told you he's still in pain?
Yes, I remember that.
All right. Do you recall Mr. Baez asking you about the amount of fentanyl he had received during surgery and during his hospital stay previous to the palliative extubation?
Yes.
Had you added that up yet in your mind
Have I,
at the time of the palliative extubation?
I did not sit there and add it, but there was a running total on the bottom that allowed you to see just what he got in the drips. But that was not something, I didn't include other breakthrough medications, OR dosing, things like that. I knew, though, that that bag of fentanyl had been refilled multiple times, which left sort of a running total at the bottom.
All right. But once again, these are not your decisions regarding the amount and type of drugs. These are Dr. Husel's decisions, correct?
He's the prescriptive power.
And you said one of the things that was in your mind was that because of what you knew, that he was had been at least reported in the medical records, an opioid user on the street, that he had an opioid tolerance, right?
An opioid tolerance.
So 1,000 mics, 10 milligrams. What about Mr. Millett, this 74-year-old guy that came in? Was he a known opioid user out on the street?
To my knowledge, no.
And what did he get?
1,000 and I think that was 4.
And Mr. Allen, the 81-year-old man, was he a known opioid user out there on the street?
He wasn't using street drugs, no.
All right. And what did he get?
1,000 and I think that was 6. And then there was 2 of hydromorphone.
Okay. And in fact, Mr. Millett, when he came in, what medication had he received prior at all during his hospital stay there?
I think you said Tylenol.
Well, is that what's in the medical records? You've had a chance to review them?
Yeah, I had a chance to review them for Mr. Millett. I'm just thinking, I'm sorry. Yeah, yes, that's what I remember.
All right. So you would agree, or would you agree, that the guy with the known drug tolerance from the street who had surgery and everything else got, at least initially, the same as Mr. Millett and Mr. Allen, as far as fentanyl goes?
Objection.
It's
Overruled.
patient specific.
So these 3 patient-specific doses for the fentanyl were 1,000 micrograms?
That's what we settled on.
The medical records don't always tell the whole picture. Remember that line of questioning with with defense counsel?
Yes.
All right. You do have time to sit down after the fact and chart these things out, right?
After the morgue care and taking the patients to the morgue and things, yes.
Okay. So you would have had time, had you seen the pain and things that you've testified to that aren't charted, you would have had time to go back and put those things in the medical records at some point after the fact.
There was time to do that, but I didn't.
Nothing like being at bedside. Remember that line of questioning?
Yes.
So we have Dr. Husel at bedside, we have you at bedside, we also have the family members at bedside, right?
I agree.
And you had to go back and review this, Danny Millett, James Allen, and Mr. Timmons, right?
I reviewed them.
Because these were one of thousands of patients that you cared for during your time at Mount Carmel, right?
That's correct. I cared for a lot of patients.
So those families that were there,
Objection.
I haven't heard the question yet, but go ahead and give me the question.
the families that were there at bedside for their loved ones, right? Based on your training and experience, is what they observed in your mind valid?
Objection. Calls for speculation.
We got a hand up. You need a break? Okay, we'll get you here in about 2 seconds here.
This is my last one.
That's your last question?
Is that my last question?
For this witness.
For this witness, yeah.
Okay.
I'm sorry, I don't know, let me go through stuff. Yeah, that's it.
Rephrase the question because technically he's correct.
Okay. You saw family members for Timmons at bedside?
Yes,
You saw family members for Allen at bedside?
yes,
And you saw family members for Millett at bedside?
yes,
And they could see and observe, based on what you saw, everything that was going on too, correct?
yes.
Thank you, I have nothing further.
Okay, you can step down. We'll take our break. A little early, but I'll give it to you. Looks like you could use it. David, call him up.
All rise.
Remember the admonition, 15 minutes, guys. We'll get started back 10-2. I think from looking at that clock, I like it now as a reflection. Have a great break, guys.
the hospital-associated or hospital-acquired infections.
And did you say you went to the ICU after that?
Yes, correct.
And around when was that?
Around 2016, February-ish of 2016.
Did you have any training or orientation when you joined the ICU?
Yes, so in the very beginning, when you're a nurse, you have like 10, 12 weeks of working with another patient or another nurse. When I went to the ICU, you went back through another orientation period, 10, 12 weeks of working with another nurse in some classes that you have to take, and some online classes and in-person classes.
Did you have any specific training on palliative extubations?
No, just with another nurse.
And when you started in the ICU, was your work similar to your work in the other units?
No, ICU is completely different. Different type of patients, different type of medications, different assessments. Everything is different when you go to the unit.
What shift did you typically work in the ICU?
I worked the night shift, usually 7 p to 7:30, 8:30, whatever time you got out of there. But when I was in orientation, I did some day shifts, and sometimes I would come in at 1500 and do a 16-hour shift.
And what doctors did you work with?
Their night shift doctors was Dr. Hagris, Dr. Husel, and then we were a trauma center for a while, so we had some trauma residents, surgical residents, and trauma attendings.
Now, when you're starting a shift in the ICU, how do you get up to speed on, well, how do you get your patient, first of all?
We start all in the break room. The charge nurse for that night kind of gives us all of our assignments, lets us know what's going on, gives everybody if you're on the code team that night, you get assigned to the code team, or the STEMI alert, those sort of things. You get all of those assignments.
Can you slow down just a
Sorry.
little bit? I didn't understand the last thing you said after code.
Okay. They assign the code team, they assign for STEMI alerts, which is just a heart attack or a stroke alert.
To interrupt you, could you spell that for the record?
Oh, STEMI is S-T-E-M-I.
Go ahead, you can continue now.
Okay. And then you go and get bedside report with whichever nurse is off going.
What is that bedside report typically like?
The nurse gives you a overview of what is going on with your patient, why they're there, all the different medications they're on, anything that happened within that last shift, and anything that you're expecting to happen, anything that didn't get done that day too.
Okay. I want to take you to January 14th, 2018. Were you working that night?
I was.
And what patient were you assigned?
That patient was Miss McDonald in room 7.
Is that Brandy McDonald?
Yes.
Okay. And did you have a meeting with the nurse from the shift before to get you up to speed on Miss McDonald's condition?
Yes.
Had Miss McDonald been your patient prior to that night at any point?
No, although I was aware of her because I worked that night before morning-ish when she came into the unit.
What was your understanding of Miss McDonald's clinical status when you started your shift?
Do you want me to give you an overview of everything, or just when I
Yeah,
met her?
just generally what was her, yeah.
So she was so young. She was 37. She had ovarian cancer that had spread to her lymph nodes and to her liver. From what I understand, she was on our regular oncology floor. She had been in a clinical trial, which is like an experimental treatment at Meister Center, which is just Mount Carmel's cancer center. And those medications that she was on, they were worried were hurting her liver, and so they had sent her to the hospital to get treatment for that. That night, 13th going into the 14th, she had become really short of breath, and the doctor had been called to the bedside. She wasn't doing well. She ended up going to a CAT scan and then coming to us. And that's when I knew of her, because I was working that night. And I was in room 6. The floor doctor and Dr. Husel were in the nurse's station right in front of me. And the floor doctor was telling Dr. Husel about this patient that wasn't doing well. I think he was upset because her lactic acid was really high, and he hadn't been notified of that. And he was telling Dr. Husel about him, and Dr. Husel was like, just bring her now, we'll take care of her. It was like almost shift change. So that's when they did bring her after the CAT scan to room 7. The other nurses took care of her, and there, I think that was when she went into respiratory arrest, and Dr. Husel intubated her, got her stabilized, then, we all went home. So then that night was when I came back in, so 7 o'clock, that's when I had her. She was assigned to me. The outgoing nurse had told me that she had continued to get worse during the day. They, family and the daytime physicians had talked, and they decided to change her code status to DNR CCA. She wasn't getting better, she kept getting worse. They tried continual renal replacement therapy, which is like dialysis that we do in the unit continuously. And her blood pressures dropped down into the 60s. She was put on Levophed, which is a pressor that helps increase your blood pressure. She was put on vasopressin, same thing, helps increase your blood pressure. She was on a bicarb drip that was to help for her acidosis. Her pH at the time that when I came on was like either 6.8 or 6.9. That is not good. It is not good at all. Her lactic acid was like 27. So really she was in the part where she was, she was actively dying at that point. I was told that she was maxed out on her pressors, which just means that we can't go any higher on those pressors. And they gave me the last ABGs. They had it on a sticky, that's what a sticky note, that's why I remember it. And she was getting a bolus to try to help increase her blood pressure, because I think at that point her pressures were in the 70s.
Okay, thank you. I'm going to show you.
Hold on.
Oh,
You
sorry.
said ABG?
ABG is an arterial blood gas, kind of gives us,
I just wanted to know what it was. You guys use acronyms all the time.
I'm sorry.
I get confused, so.
I already showed these to defense, and we've agreed just to publish
Okay.
instead of walking back and forth. I'm going to show you States Exhibit 5E. All right. Down here at the bottom, is this one of your nursing notes from that
Yes.
night?
Yes, that's one of my nursing notes.
And could you tell us the significance of what you were charting and why you were charting at that point?
So when you come on, we do assessments. So first thing, I had gotten a report and I went to do my assessment. Her blood pressure was still low even after she had gotten the bolus. And that's last lactic is what was on the ABG, what was her lab results. So I was calling to let him know that what her lab results were and what her blood pressure was.
Right. And then turning to the next page of States Exhibit 5E. Is this your next nursing note from that night?
Yes, but we had other things that went on in between there. But yes, that's my next nursing note.
Okay. I guess could you tell me what other things went on in between where we were and entering the DMRCC code change?
So earlier in the day, I think the chaplain's notes and the physician's notes had said that if she continued to deteriorate, that family wanted to withdraw care. So they wanted to do a terminal withdrawal or a palliative withdrawal. So at the point that she wasn't getting any better, and I had let Dr. Husel know, the family was either in the waiting room or he was calling them to come to the bedside to let them know that, she wasn't getting any better and what did they want to do. And this next note is where all the family was there. I believe the chaplain might have been, I don't know.
It's okay, I know it was a long time ago.
Yeah, I was there. Dr. Husel came in to speak with the family to let them know that she wasn't doing any better and to ask what their next steps. Did they want to keep her the DNR CCA, and we would continue to do what we're doing, or did they want to go ahead and withdraw care, which is what they had said earlier in the day they wanted to do.
Okay. To the best of your memory, who all was present from her family for this meeting?
She had a lot of family in the room. I know that her mom and her dad and her boyfriend, husband, her long-term boyfriend, was there in the room.
And as a result of this discussion, is that when the code status was changed?
Yes, that was, then I received orders for the palliative withdrawal.
Okay, and can you tell me about those orders?
Sure. So Dr. Husel gave me an order for 1,000 of fentanyl, 1,000 micrograms of fentanyl, 6 milligrams of Versed. I went into room 6 to put those orders in. I put in a palliative withdrawal order set, and I put in the order for 1,000 micrograms of fentanyl. I notated on there that it was for palliative withdrawal, very clear what it was for. I put in the order for Versed. I then went and talked to my charge nurse because I didn't do these very often. I wanted to make sure I was doing it right. I talked with him and asked him if he would go in with me to do the palliative withdrawal.
When you say him, sorry, are you referring
sorry.
to your charge nurse?
My
or-
charge nurse. That nurse that day was named Jason Schultze,
Okay.
and I do not know how to spell his last name.
It's SCHULTZE. Continue.
That's to help and not
Yes, to help
interrupt.
Sam, not for you, yes.
And he said that yes, he would go in with me. I just mentioned to him, I was like, hey, he ordered 1,000 mics, and he was like, yeah, he does that. And I was like, okay. I went to the Pyxis to get the medications out. I overrode just like I would have done with any other physician giving me a verbal order with a bedside procedure. Removed the medications. As I was removing the medications, another nurse, Tyler Redmond, had come up to me, saw what I was doing, asked me about what I was doing, told me that I needed a bigger syringe, went to our storeroom and got me a bigger syringe. And so then I took my meds and my syringe, I went to room 6. I didn't have a patient in room 6 at that point. We have all of our supplies in our rooms. So I drew up the medications while I was drawing them up. They're in little vials. Dr. Husel was standing there talking to me, and he was like, oh, you have to, do all those little ones. And I was like, yeah, this is kind of a pain. And he was like, oh, well, in the OR, we have them in 400 microgram vials. So they're, in a bigger vial in the OR. And he said, this is the dose that we give before we do the first incision for open heart surgery. And I thought, well, great. If it's enough to cover the pain for open heart surgery, then obviously it's going to be enough to cover the pain and the distress that this lady is going to have when we remove her from the ventilator and she, in essence, suffocates to death. So I said, great. Finished pulling all of that up, got my charge nurse. We went into the room. I don't remember if all the family stepped out or if only, I feel like there was one other person in there because I remember warning them that there was going to be a noise because there's a gurgling noise when you take out the endotracheal tube. And so we gave the medication, turned off all the medications that were keeping her alive, and withdrew the tube. Then family came in. I believe the chaplain was there at that time also. I left the room. I went to the nurse's station to catch up on all my charting, everything that we had just done.
Okay, to unpack a few things that you just touched on, when you removed the medication from the Pyxis, did you say that was via override?
Yes.
And were you doing that, was this a planned procedure or was this more of an emergent situation?
It's not an emergent situation, but it is urgent. But I didn't override because it was emergent. I overrode because it was a bedside procedure, that the physician is there giving orders, and in that case, we are allowed to.
So Dr. Husel was standing with you?
He was within the nurse's station, within eyesight. I don't believe he was standing right next to me, whereas when I was pulling it up, he was standing right there with me.
And to clarify, did you wait for a pharmacy review before pulling that?
No, they reviewed and approved it later.
All right. Why did you take the vials of medication to the separate room?
Because that's where all of our other syringes were, like the syringe for the Versed for me to be able to pull up all of our flushes were, all of our needles are. So that's where I went to get them all.
And after you said you left the room after you administered the medication, how did you come to learn of Miss McDonald's death?
So we have monitors, like the monitors in the room, you can turn to a certain setting so the family doesn't see or hear all of the beeping, but we can still see it at the nurse's station. So I could watch on the monitor at the nurse's station.
And what would you see on the monitor then?
You could see her respiratory rate, you could see her heart rhythm. She had an arterial line in, so you could see what her blood pressure is continuously. You could see what her saturations were for her oxygen saturations. And did I already say heart rhythm? I think so. Anyways, heart rhythm, that too.
And were you the person that called the time of death?
No, I'm not a doctor. Doctors have to do that.
So would that have been Dr. Husel?
Yes.
Was he with you at the time or when you're watching the monitors, or did you have to notify him after the fact?
I don't remember.
Okay. And I would like to go through some of the medical records with you. I think that you were referencing, well, before we switch off of State's Exhibit E5, were these your final two nursing notes of that night?
Yes, so after someone passes, you have to call all of their consults and let them know.
And is this the 2205, is that the time of death that would have been called?
That is the time of death, yes.
And then just looking at this one, the 2130, is that when the conversation would have taken place?
Around that time, yes.
For the DNRCC?
Yes.
All right, so State's Exhibit 5F. Starting with this respiratory rate, could you describe what that is and what you're charting here?
So the respiratory rate, they have monitors on or leads on that go to the screen that tells you what the respiratory rate is all the time. Respiratory rate is just how fast or slow you're breathing. There in the beginning with the other nurse, she obviously was breathing pretty fast, 39, 38. 2130 is around where I extubated her. So 2151 was minutes after, 2151 is where I extubated her, so, or around there. So her respiratory rate was 19, 2156 was a few minutes after that. It was just another vital sign charting that I did, and then 2205 is when she had passed.
So does the 20 indicate that her respiratory had gone up after extubation initially?
Yes.
And then is the 0 is when it goes down for the time of death?
Yes.
All right. On the second page of State's Exhibit 5F, can you discuss what this pulse oximetry is and why you're documenting that?
So that is another vital sign that is taken continuously. This is how much oxygen basically is in her blood or that she's getting. You want them to be between 90 and 100, which is a normal. So she was still on the ventilator at 2130. You can see her saturations are 95. 2151 is around when I had extubated her. You see her sats are now 78. 2156, they're 49. Obviously, they're going down because she is dying.
Going to page 3 of this exhibit. Starting here, the device FiO2 percentage.
So that's how much oxygen she was on with the ventilator. The ventilator has different settings, and you can have it set to where it does the entire respiratory cycle. It breathes for you, so how much oxygen you're giving, how long their inspiration, how long their expiration is, how many times they're breathing a minute, and that's just, they were on 40% of oxygen.
And then turning to the pain scores, looking at these last two, when you documented the 10, was that is after the decision to do the DNRCC, correct?
Correct. That was when I extubated her and gave her the fentanyl.
Were you observing pain at that time, or was this an anticipatory pain score?
This is an anticipatory pain score. What I thought.
Could you elaborate on what that means?
Sure. So when someone's on a ventilator, completely dependent on the ventilator to breathe, and then you remove that, they are no longer going to be able to breathe, or at least breathe well enough to, keep themselves alive. And when you remove all the medications, keeping them alive, that, in essence, they suffocate to death. So that was me saying, I think this is going to be incredibly distressful and horrible for my patient. So that's why I'm giving her the fentanyl.
And had you observed her to be in any pain prior to giving her that 10?
My first assessment there is 1944, and I put a pain score of 0. When I looked back, when I looked back, I saw like her heart rate was high when I first came in, her respiratory rate was high. So she most likely was in a little bit of pain, and I was too focused on her blood pressure dropping to realize that.
Turning to the next page of this exhibit, is the pain level acceptable?
I charted at 1944 that it was 0, so yes, that it was acceptable.
The next page of the exhibit, looking at the eye-opening response, Glasgow. Could you tell us what that is?
Sure. So that is a coma score that we do whether or not our patient is having certain responses as far as when we call their name, do they try to open their eyes? Do they look at us? Do they have certain reflexes? It's a neurological assessment. She was, all of her organs were shutting down, so I wouldn't expect a response. So since the beginning, or since that morning, she hadn't been responding. She had been unresponsive to us.
Turning to the next page of this exhibit, the verbal response, is that on the same Glasgow coma?
Yes.
And when you're scoring her a 3, what does that mean?
So the computer adds it up together, and 3 is just the lowest of that coma score. When someone's a 3, there is a order that you have to call LOOP, which is our organ procurement here in Columbus, Ohio, and you have to notify them that you have a patient that could possibly be an organ donor, is why you have to call them.
Now, looking at the next page of the exhibit where we see oral secretions, and you put none and see below, could you discuss what that means?
So the oral secretions are just like what secretions she had in her mouth. It would be that next over where it says, is the patient having pain? There was a whole lot of places we had to chart the same things over and over again. So this, if you see where it says T391 and T425, those are just little things that we annotate. Like if you look down, it says patient unable to self-report pain, unable to self-report pain. So that was me charting that.
Turning it to the next page, are these your notes where they had those little T?
Yes, that she was intubated, sedated, that she was over-breathing the vent, and she was guppy breathing. What I mean by guppy breathing is that she was going, and I mean, and that that does happen when someone's pH is so low and when they're actively dying, so. Yeah, and that other one is when I withdrew from the ventilator, when you put the pain score in, the program makes you like go through a couple different things, and that's one of those that it makes you do, so that she was unable to self-report pain, that I was giving this medication anticipatory because I was removing her from the ventilator.
And what is the significance of patient overbreathing the vent?
I'm sorry, I didn't hear.
Where it says she's overbreathing the vent, what is the significance of that?
So, well, one that showed that she was in a little distress or some distress. Like I said, I should have noticed that. But so when people are in distress, they're breathing really fast. So the ventilator is set on a certain rate for her to breathe, and she was over-breathing that rate.
Then, just looking at this last one, pain relief, when you put C below, what are you documenting there?
So T421. So this is one of our, you see I did it at 2009. This is every 2 hours we have to chart certain safety things. And this is just one of those every 2 hours you have to chart like what sort of interventions are you putting in place that your patient isn't in pain or that you're taking care of your patient. And that would be comfortable environment, peaceful environment, positioning, rest. Those are all interventions that we do kind of continuously to help our patient.
And was this and the 0 pain scores before or after the order was given for the fentanyl and the midazolam?
It was before.
Just turning briefly to State's Exhibit 5G, is this the note that you were talking about where you documented?
Yeah, so when I put in the order for fentanyl, I specifically put for ventilator withdrawal, so pharmacy would be aware of what I was ordering it for, and I know that I did that because I misspelled withdrawal, so.
And finally, turning to State's Exhibit 5H, is this the medication administration record for Ms. McDonald?
Yes.
And looking at this right here, were you aware of this administration of medication earlier in the night when you started your shift?
I don't remember if I was aware at that point, unless I would have seen it on the MAR.
Did you become aware of it at any point during your shift?
I don't remember.
Okay. The next page of the same exhibit, is this the order for the midazolam and the fentanyl?
Yes, those are the orders I put in, and those are the medications that I gave.
And it looks like, what time was this order put in?
I put them in at they should be 21:31. Yeah, I put the orders in around 21:31 after we had the discussion with the family,
And what time did you administer them?
around 21:51.
Right. I have no further questions.
Baz, we got about 5 minutes before we have to cut. Do you want to do it now, or do you want us to do it all at once?
I don't think I'll be long, but we both know how that goes.
I'm gonna take a chance on you. You're the one who'll get cut off.
It's up to the jury if they want to take a break now.
We're not taking a break, we're going to go to Dellinger
Oh,
at 3:30.
in that case, yeah, I will
Okay.
make use of this 5 minutes.
Let's take 5 minutes so we can get the screen set up for the next witness.
He said the other thing.
Oh, you wanna do the questions?
It's all right.
Well, everybody was talking, I was talking to you, so you got everybody's input. You wanna do it, do it.
Sure. Good afternoon, Ms. Burke.
Hi.
Just a couple quick questions before we have to break. You mentioned that the pharmacy verified it after the fact, correct?
Correct.
And that was this all occurred, and I'm just showing you I'll just bring up State's Exhibit 5H. The date of all of this occurred on January 14, 2018, correct?
Correct,
And the pharmacist who verified the order was Talon Schroyer, correct?
correct.
And fair to say that January 14th, 2018 came before October 24th, 2018, correct?
Correct.
I'm ready to take a break now.
No, you're still going,
You
dude.
want me to keep going?
Yeah, I wanna see if you can get it done in 5 minutes.
No, I didn't say I was gonna get it done.
Ah, you stepped up.
I'll keep going.
Let's get a couple more minutes of it.
Now, having said that, you testified under direct examination. I'm showing you Joint Exhibit 5, page 286 to 287. This is the same document you went over with the prosecutor, right?
Correct.
Now, the event was set at 30?
I don't remember.
Okay. Actually, 34. Does that sound correct?
It could be.
If I showed you the order that was entered earlier that day, would that help refresh your recollection?
Yes.
May I approach?
You may, or you can show it to her on the screen. You guys all stipulated the records.
All right. Showing you Joint Exhibit 5, page 172. Do you see right there where the order for the ventilator is set at 34?
Yes.
Okay. So when someone is, as you mentioned, breathing over the vent, that would show, it would have to show over the number 34, correct?
Correct.
Now, here, earlier in the day at 6 p.m., 1838, which would be 6 p.m., she's breathing at 39 breaths per minute, correct?
Correct.
Now, the normal rate, respiratory rate, would be between 12 and 18,
Correct.
correct? So she's breathing pretty fast,
Yes.
breathing even faster than the ventilator is breathing for her,
Yes.
okay? And she's doing that throughout the day for hours.
Correct.
And right around here is where she gets the palliative withdrawal, correct?
Correct.
Now, can you tell the ladies and gentlemen of the jury about when a patient tires out on their respiratory rate?
You mean as far as within the palliative withdrawal or just
In general, with their reserves?
So at first you would see usually someone breathing fast. They're going to be breathing fast, kind of huffing and puffing. Usually they look like they're in some distress. Sometimes they're like wheezing, that sort of thing. And then as it wears on, then the respiratory rate decreases, as they're tiring out from breathing too fast.
So a person can eventually stop breathing because they've been breathing so fast for so long.
Correct.
Now, when Ms. McDonald had the withdrawal, her breathing was at 19, freshly off the vent, correct?
Correct.
And then it actually went higher, correct?
Correct.
And that was approximately 5 minutes later?
Correct.
And you would have given the fentanyl before extubating her, correct?
Correct.
So this tells you that the fentanyl did not affect her breathing, correct?
Sustained. Good time for a break. Because it's getting close to our time. Ladies and gentlemen, we need a couple minutes to set up. I'm going to send you out of the room. Stretch your legs for a second, and we'll get started in a couple minutes.
All rise.
Do we have Paul? Okay. Just relax. We'll take care of you, don't worry.
What? What's Taylor? Layman blaming you for everything, man. You just turn around and blame me. God, it's that Zion
Okay.
stuff. That's what we can't get stipulated, so.
Okay.
I have that as well.
All right. So I will refer to that as 18L. I don't think we can share the screen using what we have set up.
Okay,
We
you
all
can.
agree that this is.
You can.
I
Well,
have it on my monitor.
you're looking on your monitor for when you got electronically, correct?
That's right.
Okay. Does that work for everybody?
Yeah, Mr. Lapidus will be doing the cross-examination, but Ms. Menashe says that should work.
Where is he?
Grants the rest of the judge.
We're gonna send you all to the doctor this weekend.
We'll start in just a minute here, Doctor. Thank you. It's Mark. Dellinger. D as in David, E-L-L-I-N-G-E-R. Thank you. Well, you can use that as well, so it should be the same exact thing. I think we're all set here, Judge. If we can get the jury back.
Jurors.
Yeah, okay. Thank you, Your Honor. The state of Ohio calls Dr. Dellinger to the stand.
Dr. Bellinger, raise your right hand. You solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God.
I do.
Okay? I need you to state your name for the record and then spell it for my court reporter, please.
My name's Mark Dellinger, M-A-R-K. Dellinger is D-E-L-L-I-N-G-E-R.
Are you guys hearing him okay? Mr. Zion?
Sir, what do you do for a living?
I'm an internal medicine physician that focuses on hospital medicine.
All right. How long have you been so employed?
Came out in 2000, so 22 years or so.
What kind of education starting at college did you get to do what you do?
So I have a bachelor's of science in biology. From there, I went to medical school. That's 4 years. Then there's 3 years of residency, and then I started practicing.
And when did you go to medical school?
I think it was 1993 through 97, I believe.
And where did you go to medical school?
I went to what was called Medical College of Ohio. It's now part of Toledo University.
You said Toledo University?
Right.
Okay. All right. And then what was your residency in, please?
Internal medicine.
Okay. And was this a subspecialty that caring with people in hospital or just internal medicine in general?
It's internal medicine in general was the residency program.
All right. And are you licensed to practice medicine in the state of Ohio?
Yes.
And are you board certified in internal medicine?
Yes.
All right.
It's internal medicine with the focus in hospital medicine.
All right. And you started that, you said, in 2000?
That's right.
And where did you first work back in 2000?
I'm sorry, did you say where?
Yeah, where was your first job out of residency?
Well, I started a practice doing hospital medicine, and I was at Mount Carmel West, and I was also seeing patients at St. Anne's Hospital in Westerville.
All right. So were you actually employed by the hospital, or did you have a separate medical group that was contracted with by the hospital?
No, I was not contracted with the hospital or employed by the hospital.
You were just doing this independently when you say you started a practice?
That's right.
All right. In November of 2018, did you have any involvement with the care of a woman named Sandra Castle?
Yes, I did.
All right. And what was your involvement in general? What was your role in general with her care?
I was listed as her attending. I saw her on one day during her hospital stay.
All right. Had you previously seen her outside of the hospital or at any other time?
No.
All right. How did you become her attending?
I see patients, at that time I had seen patients for primary care physicians, and she was assigned to me through that process.
All right. So what do you recall? You've had a chance to review the medical records from this hospital stay that began on November 10th of 2018?
Yeah, the document was 1,000 pages, so I reviewed my progress note and I perused some of the other notes.
All right. So tell the ladies and gentlemen of the jury, please, what was your involvement? You said you saw her one time. What did you do during that one time you saw her?
That's right. So when I saw her, I came into the room and I spoke with her son, who informed me that they wanted to withdraw care on her. Prior to that, I'm sure I had reviewed her records and prepared my note. And then I spoke with the son and would have finished my note at that point.
And do you recall what date that would have been?
I'd have to refer to the chart.
Could you refer to the chart to refresh your memory?
11/13/2018.
All right, do you recall what time that was?
According to the chart, it was at 2:28 PM. Now, that's when, I don't know, based on this documentation, whether that was when I started my note or when I signed a note. I don't know how that document displays that. It just says 2:28 PM.
All right. So was this your first and only contact with Ms. Castle and her son during her hospital course between November 10th and November 13th?
Between those dates, yes.
All right. And your note indicates that this was sometime in the afternoon of November 13th?
I may have seen her in the morning and may not have finished the note until 2:28. That's possible. I don't know what time of day it was.
All right, but sometime during the daytime of November 13th, is that fair?
Yes, yes.
All right. Thereafter, are you noted as doing any documentation in the medical records of Sandra Castle for her hospital stay between November 10th and November 13th of 2018?
I did not catch one of the words in there, did I?
Thereafter,
I didn't catch the verb.
did you do any more documentation, or did you do any more documentation in those medical records?
Not according to what I reviewed.
All right. Did you do a discharge?
I may have done the discharge summary. Yeah, the discharge summary, yes.
Okay. Tell the ladies and gentlemen of the jury your understanding of the discharge summary in general, and then explain to them what you reviewed to write that document.
The discharge summary is basically a statement regarding the patient's hospital course, and then I would have referred to my note to create that, as well as if I needed to, and I don't know if I did on this chart or not, but if I needed to, I would have reviewed other notes, but I would have reviewed the other notes before I formed my first chart. So it's basically, I would have done some review of the medical records.
All right. In general, was it your practice to review the medication administration record in preparing a discharge summary?
No, not for a patient that was palliative extubation.
All right. And do you have any memory of reviewing the medication administration record of Ms. Castle when you prepared your discharge summary?
No.
All right. So were you, in any other way, were you otherwise aware of the amount of opioid pain medication and/or benzodiazepines Ms. Castle was administered during the palliative extubation that occurred that evening?
No.
What cause of death in your discharge summary did you list?
Anoxic brain injury.
All right.
I don't think in that document it was listed as her cause of death, but in the death certificate that was the case.
All right. What was her final active diagnosis in your discharge summary?
I had mentioned anoxic brain injury as well as some concerns for seizures, and I also noted cardiopulmonary arrest.
All right. And were those things that you found in reviewing your note and the summaries that were listed in those records?
Yes.
All right. Thereafter, was it your duty or part of your care for Ms. Castle to sign her death certificate?
Yes, the death certificate would come to me.
All right. And by stipulation, we have sent you that death certificate for the record labeled 18L. Do you have a copy of that death certificate?
Yeah, I'm looking at it right now.
And is that your signature on that death certificate?
Yes, it is.
And what do you put as a cause of death on that death certificate?
Anoxic brain injury.
All right. And when you signed the death certificate, had you at that point reviewed the amount of opioid pain medication and benzodiazepines Ms. Castle had been given in the ICU at nighttime during her palliative extubation?
No.
Thank you, Doctor. I have no further questions. There will be another attorney up here in a minute to ask you some more questions.
Thank you.
Just a brief moment to set up, Your Honor.
They're gonna hook up a computer, give us a second.
Good afternoon, Dr. Dellinger. How are you?
Good. Thank you. Good afternoon.
So, one moment. Just at the outset, Doctor, I wanted to clear something up. You indicated on direct examination that you saw Ms. Castle once, and that was it? Is that accurate?
During that hospitalization, that's correct.
Okay, that's what I wanted to clarify, because isn't it true that you actually had seen her several times in the weeks preceding that hospital visit?
I remember on the records that I reviewed, there was documentation that I had seen her during a prior hospitalization.
Okay. Well, let's start. Do you recognize the document in front of you as a medical record for Ms. Castle?
Yeah, thank you. I see her name, yes.
Okay, and do you see, and for the record, I'm referring to Defense Exhibit SC2, or excuse me, SC3, sorry, Sam. Do you see your name under discharge summary there, Doctor?
I see, yes, yes.
Okay. And this would indicate that you did the discharge summary when she came to the hospital on an admission date of October 27, 2018, and she left days later on October 30th of 2018, correct?
Yes.
Your Honor, I would object to the relevancy of this.
Where are we going with this?
It's the course of her care, Your Honor. This is her attending physician for 3 hospital visits prior to the one that ultimately she passed away on.
In the hospital.
And he took care of this patient.
Okay, I'll give you some leeway, but let's tie in.
This is the next page of that document. This is still the same discharge summary you authored yourself, right, Doctor?
It appears so, yes.
Okay, and this indicates that on October 30th, when she was discharged, you actually indicate that she had also been in the hospital for a form of internal bleeding a month prior to this as well, correct?
The first sentence states that, yes.
And that she had came back on this date of October 27th with involuntary tremors, correct?
Yes.
Okay. Now, let's go to SC4. Doctor, do you recognize this document as being a medical record for Ms. Castle as well?
I've not seen this, but it appears to be emergency record from November 8th. Maybe I might have reviewed this. I'd have to see what else it says, but
And again, you're listed as, sorry, can you go back up?
He's right there.
No, can you go up? You're listed there as the attending physician, correct?
yes,
And this is for the admission date of November 8th to November 9th, correct?
yes,
And this is the visit immediately preceding the next visit in which she will ultimately pass away, correct?
I imagine so.
Okay.
Yes, I mean, there's not much time between the two, so I would believe so, yes.
Can you go to the next page, please? And you see where it says history of present illness, doctor?
Yes,
Would you agree this is an accurate assessment of her current medical issues that she was experiencing on November 18th, or November 8th to the 9th of 2018?
I would have to say that it would be accurate. I've not read this, but
Let's go to the next page.
I believe it would be accurate.
Do you see there where this emergency doctor is or rather the nurse in this note is indicating that she spoke to you when Miss Castle arrived to the emergency department?
I see emergency urgent care, medical decision making. I don't know who wrote this. I see the last sentence, the second last sentence says, discuss care with Dr. Downs, rectal workup was completed, and a decision was made that the patient need to be placed in the hospital overnight for cardiac workup of the chest pain.
Do you see there at the beginning where it
I think it would
indicates,
be,
Doctor, do you see at the beginning there where it indicates labs, EKG, chest x-ray, extensive chart review, neurology consultation, pulmonology consultation, cardiology consultation, and the discharge summary were reviewed with you?
I don't know that that means it was reviewed with me. I think that means that they reviewed it themselves.
Why do you think this emergency room nurse decided to talk to you about Miss Castle when she came back for the third time in a few weeks?
Objection, Your Honor.
Sustained.
Is it fair to say that she wouldn't have spoken to you if you didn't have any knowledge regarding Miss Castle's medical problems?
Objection, Your Honor.
Sustained.
Let's go to page 49, please. And you did in fact treat her when she came on the 8th to the 9th that time, correct?
If you would show me a note of mine, I could verify that, but
Let's go to the bottom, please. Would it refresh your recollection to see the note that you made on November 9th, 2018 at 12:15?
yeah, if you showed it to me, I could get some idea whether I saw them or not. Looks like this is a note from me on the 9th. Okay.
Does that refresh your recollection as to you having treated her personally on that day?
I don't remember any particulars, but it looks like I saw the patient on the 9th. Yeah, I would say yes, I saw her.
And you made it a point to start that summary with an indication that she in fact is returning back to the hospital with chest pains and tremors?
I note that she returned back to the hospital with chest pains and recurrent tremors. That's correct.
As well as headaches and lightheadedness?
Frontal headaches as well as some lightheadedness, right?
And in fact, she had so much stuff going on, she indicated to you that and asked you whether she was going crazy?
Yes, she asked me if she was going crazy. That's correct.
Okay, let's go to page 7, please. You also did the discharge summary for when she came on the 9th, correct? Or from the 8th to the 9th?
That looks like a discharge summary with my name on it, yes.
Okay, and you see
But that's
that,
is that the fourth?
you see the admission date of November 8th and discharge date of November 9th?
Okay, yes.
So this would indicate you did the discharge summary for her the day prior to her coming back to the emergency room on November 10th?
It looks like it was completed on the 14th, according to that document.
Well, we're going to get into that. But is it not accurate that you did the discharge summary for the visit where she came on November 8th and left on November 9th prior to returning in an emergency on the 10th?
I did the discharge summary, yes.
And in fact, you did this discharge summary for this visit the day after she had passed away, did you not?
Yes.
Can you scroll down? And you indicated that she had been observed for transient chest pain and recurring tremors, correct?
Yes.
And she was discharged to go home, was she not?
Yes.
Okay. Now let's go to, for the record, I'm now going to refer to Joint Exhibit 11, page 20. Or, excuse me, Joint Exhibit 12. Thank you. And to your knowledge that Ms. Castle then returned on November 10th as an emergency, correct? Scroll to the bottom, please.
Yes.
And in fact, she had been with her spouse, and then he noticed that she was unresponsive and gurgling at home and rushed her to the hospital, correct?
I don't know the details of who she was with.
Okay. And to clarify, you indicated that prior to speaking to her family members, you reviewed the notes of other physicians, correct?
I would have, yes.
And that would include the physicians such as Dr. Mahoney, correct?
It's possible.
Go to the next page. Go to the part right above where it's at. Does it refresh your recollection that you would have reviewed Dr. Mahoney's note prior to speaking to Ms. Castle's family, where Dr. Mahoney indicated that Ms. Castle was critically ill?
Your Honor, I'm going to object to the
Sustained.
testimony of Dr. Mahoney through Mr. Lapidus.
Let's do it right. Let's ask him if that refreshes his memory.
Doctor, in reviewing this note by Dr. Mahoney, does this refresh your recollection as to what you reviewed prior to speaking to Ms. Castle's family?
No, I can't say that I reviewed that record first. I don't know when I generated my note or saw the patient relative to when he entered his note.
Okay. Do you see there, well, can you go back to the previous page, please? Again, we're now on Joint Exhibit 12, page 20. Go to the bottom where it says consultation. You see there that Dr. Mahoney's note
Once again, Your
is,
Honor, I'm going to object. He says he does not remember Dr. Mahoney's review in that particular.
he didn't actually say that. He said in regards to timing. I'm now establishing the timing of this note in relation to when he spoke to Ms. Castle's family member.
Okay, well, you can go there, but the way you're going about it, just let's be a little bit more direct instead of a long trip.
Understood. Doctor, do you see that Dr. Mahoney wrote that note on November 10th of 2018 at 2:21 in the afternoon?
I see the timing on there, but as I mentioned earlier, I don't know if that's when, according to the computer, when that note was started or when it was finally signed off upon. So I don't, that's all I can tell you about that.
Can you go to page 11, please? Okay, just to orient ourselves, Doctor, this is also a note for Ms. Castle for the visit of November 10th, 2018, correct?
Yes, this is a note from the 10th, right?
And you are the attending physician, correct?
When she came in, I don't think I was the attending at that point. According, when this document was generated, it probably drew me in, but at that point, I don't think I was the attending. I think the patient was transferred to my service later.
And that would be when she was transferred to the ICU, correct?
I don't know when it was exactly.
Okay. Do you recall speaking with Dr. Mokanor? I'm sorry if I butchered that pronunciation. Do you recall speaking with this doctor?
No.
Okay. Would it refresh your recollection to see Dr. Mokanor's notes regarding the conversation he had with Ms. Castle's attending?
If he listed that he spoke with me, that may help, but I really don't think that we spoke.
Do you see the line at the very end of that paragraph where it indicates that he discussed the case with the ICU attending? And it
Yes.
states that she does have reflexes and was withdrawing for painful stimuli? That would be you, correct, that he spoke to?
No, that's incorrect. I would not be the ICU attending.
Okay. But this is one of those notes that you may or may not remember having reviewed prior to speaking to Ms. Castle's family?
This is the initial, what they call the history and physical that was initially generated when she first came in. I would have referred back to it if I needed to when I saw her. Yeah, I can't say that I did or I didn't.
And you, just to clarify, your company is Columbus Inpatient Care?
No, that's not right.
So you don't have a company named Columbus Inpatient Care?
No, I do not.
Now, you said on direct examination that you saw Ms. Castle once, correct? And that was when you spoke to the family member?
During that hospitalization, the final hospitalization, that's right.
Let's go to page 66. We're still on the same joint exhibit, Sam. We're going to page 66. The bottom, please. Joint exhibit 12. Actually, just go to 67. 67. Doctor, that indicates you were the author of this note, does it not?
Yes.
And this would indicate that you saw the family at bedside and reviewed the
Wait.
care with them?
She's not, yes.
Okay. And you would agree with me that this is that this is a time in which you saw Ms. Castle and spoke to her family?
On that date, yes.
You would agree with me that there's no references to seizures there?
I don't think, there is, at the bottom of what I'm seeing, I don't know if part of mine's cut off, but it says non-convulsive status epilepticus, which is a seizure.
Okay. Now, let's go to page 82. Doctor, do you see here, again, this is a note from Ms. Castle, correct?
Again, Your Honor, I'm objecting to them showing other doctors'
Yes.
notes.
Do
Okay.
you see where it says,
Hold on. Where are we going with this?
it literally says progress notes, Mark Dellinger. It's his note for when he saw her a second time.
Is that where you're going? Because you showed the notes to somebody else at the top.
Well, it's right there, Your Honor.
You can go on
Thank you.
with that note there. The
Yes.
other note
Yeah.
doesn't apply to him.
No, I just needed to scroll, Your Honor. You see this second note reflecting a second time you saw Ms. Castle and spoke to her family?
You know what, this is my note. If you could show me the first one, I'm not sure if the first one was mine. When I reviewed the records, I thought I only saw it once. I thought there was a covering doctor. That may have been their note.
New page 66.
I'm trying to look online here.
Yeah. We're going to go back to the previous note so we can show you the timestamp in which you signed that, okay?
Yeah.
Page 66.
So that would have been the 12th.
Doctor, you saw her on November 12th, correct?
When I reviewed the records, I only saw a note from the 13th from me, and I kind of perused the other ones. I really think that somebody was covering for me on the weekend, and then 13th may have been a Monday, and that's when I came on. But I'm happy to look at that 12th note, and I'm trying to find it here. I just don't see it yet.
Doctor, do you have the full medical record in front of you?
I have 1,000 pages, so it's.
I'll make it very simple. Go to page 66, Doctor.
Okay, both of you talking at the same time, relax, stop, relax for a second. Let's let him get there. He's dragging you to page 66. Have you found it?
I'm on 66 on my PDF, yes.
You see at the bottom of that page, Doctor, where it says electronically signed, Dellinger, MD, comma, Mark A, November 12, 2018, 17:34 Eastern Standard Time?
That is okay, I see that, yeah.
Now go to the next page, please, Doctor.
Okay,
You see how it says author, Mark A. Dellinger, MD on that page?
yeah. I do.
So do you agree with me that you actually saw her twice during this hospital visit and spoke to her family twice?
Yes.
And you reviewed the course of her hospital care with the family twice, not once?
Right.
Thank you. Now let's go to page 82. Doctor, can you go to page 82 of that medical record, please?
Okay, I'm here.
You see there that is a note from the next day of November 13th, 2018 at 2:28 in the afternoon, authored by yourself?
Yes.
You see there that the son was at the bedside and you discussed her brain injury and her apparent seizure?
Right.
So you would agree with me that when she was at the hospital and through the course of your care and speaking to the family that she actually suffered a seizure at the hospital based off her heart attack and head injury?
Yes, she was having seizures, that's correct.
And it was at that point, based off of her decompensating situation, that you discussed with the family their options, correct?
Yes.
It was at that point that you felt the situation was grave enough to give the family their options regarding withdrawal of care, correct?
I believe that they told me that they wanted to withdraw, and I would have discussed the other options as well.
Would you agree with me that they didn't just volunteer that they wanted to withdraw care, that probably was based off something that you indicated to them, based off your opinion of what her medical status was?
I imagine they would have used my opinion and the opinions of the other doctors to form an opinion.
And again, you reviewed the documents from the other doctors prior to speaking to the family, correct?
I would have reviewed the medical records. Like I said, based on the timing, I don't know whose records I would have reviewed and whose I wouldn't have.
Okay. So to clarify, you didn't just walk in there and talk to her family about her actively dying without having some medical basis for it, correct? Whether it be your notes or your own observations.
Exactly, yeah. I can't walk in there and not know anything. It just, you have to review things.
Okay. Now let's go to page 6, please. Okay. Doctor, could you go to page 6 of the medical record, your discharge summary, please?
Okay.
Doctor, do you see there that this is the discharge summary that you authored after the discharge summary for her prior visit as well?
Yes.
You see there the list of all the different physicians that saw her?
I see a list of positions, yes. I imagine they saw sometimes in the medical records, you can be consulted, but you never saw them, and sometimes it still shows up, and maybe what your partner saw them, but those are listed doctors.
Okay, so let's scroll down to active final doses. So I believe you went over some of the active and final dose diagnoses in your direct testimony, but I want to go through the full list of what you decided to put as to her final diagnosis when writing this discharge summary, okay?
Okay?
We have her heart attack, correct?
Yes,
We have respiratory failure, her lungs stopped working, correct?
that's correct.
She was suffering from COPD, correct?
That's right.
She had chronic heart failure, suggesting she had a history of heart issues, correct?
Yes,
She had hypertension, which is blood pressure problems, correct?
that's correct.
She had hyperlipidemia, which would be cholesterol problems, correct?
That's right.
She, with respect to Ms. Castle, you listed that she was morbidly obese, correct?
Yes,
She had type 1 diabetes, correct?
that's right.
She had unspecified abnormal movements. That would be the seizure she was suffering from, correct?
Yes,
Now, doctor, you'd agree with me that medical records are very important, right?
yes,
You wouldn't put something there that you weren't confident as to why you were putting that there, correct?
yes.
You wouldn't guess, would you?
No, I wouldn't.
Now,
No, I wouldn't guess.
and that, doctor, that applies to both the discharge summary as well as the death certificate, correct?
That's correct.
Now, you indicated on direct examination that you didn't review the medical administration record, and you didn't do that because it was a terminal vent withdrawal. Is that accurate?
You're talking about when, after the patient died?
Yes. When you did this discharge summary and the death certificate, you didn't feel the need to review the medical administration record because you stated on direct examination you don't do that for terminal vent withdrawals. Is that accurate?
That's correct.
Now, nothing prevented you from looking at the medical administration record, correct?
Correct.
You had access to it, right?
Yes,
At any point prior to writing the discharge summary or the death certificate, you could have reviewed it had you chosen to, correct?
yes,
But you felt you didn't need to prior to writing those very important final diagnoses and cause of death on a death certificate, correct?
that's correct.
You were confident in what you put on those important documents because you knew of the care Ms. Castle had received several times, including her last visit, by yourself and other doctors, correct?
Yes,
You were confident that when you put the cause of death was her brain injury on the death certificate, and when you put heart attack on final diagnosis on this document, that that's actually what had caused her death, were you not?
that's true.
And just to end on one last question, doctor, actually two, sorry. You put
Okay.
that her cause of death on the death certificate was natural, correct?
I believe, let me check, double check, but I'm sure I probably did. Yes,
Now, you put that her death was natural, and to circle back as to why you don't review a medical administration record for a patient who's been terminally withdrawn off a ventilator, is it an accurate statement to say that nothing in that medical administration record would have changed your opinion as to what you put on these documents? Because when you do a terminal vent withdrawal, the patient is terminal, correct?
yes, you're taking them off life support. There's no more support for their life. We expect them to die.
And
Yes.
she was terminal based off everything you put in that active and final diagnosis, correct?
Yes, what's the decision to take her off the life support? I believe that she was terminal at that point, yes.
Nothing further, doctor.
Redirect.
A few notes, Doctor. Could you go back to your progress note from November 13th? I think he said it was page 82. November 13th.
82. Let me
Is that
get it
what
up.
you said again? On the PDF thing you got there?
Yeah, I got it.
Got it? What's her pain score?
Yes, sir.
Did you put a pain score down?
I don't record pain scores, no.
What's noted on your progress note?
Um,
On,
well, I'm not sure what you're referring to. Should not able to provide a review assistance. Is that what you mean?
under
Patient on
objective,
vent and not able to provide. I can read the examination if that's what you want. Not alert or attentive, not interactive, no
Hey,
purposeful
Doc,
movements.
Doc, relax for a second.
Yeah.
your note starts on one page, right, on November 13th, 2018? On page 80?
I've got page 82. I go to page 80 here.
Go to where your note starts.
Yeah, I believe my note starts on page 82.
Okay. And does it end with an examination of the extremities, and then a listing of her maladies? That page, extremities, no clubbing,
that's
stenosis,
page-
mild?
That's, no clubbing, stenosis, mild edema, that's page 82 for me, yeah.
Yeah, okay. And does your note continue on the next page?
Yes,
And does it start at the top with DM, meaning diabetes mellitus?
that's right.
Okay, now go down there. Is there a pain score recorded on this document, this progress note?
Objection, Your Honor. He's indicated he doesn't
I see
take
it.
pain scores.
Okay, we got an objection.
He doesn't take pain scores, and I would ask the state to look at the date next to that, because it doesn't correlate with the note you're asking.
Okay. Note the objection, overruled. Go ahead, Mr. Zion.
All right. So as part of your review of these documents, did you note that on 11/13, on the same day as this, what her pain score was?
This information is pre-populated. So it says pain score 0, and that would be consistent with what I saw on my exam, I
Note your
suppose.
objection.
All right. So you don't do pain scores, but is that consistent with what you saw?
Yeah, right.
All right. And it was referred to on cross-examination as the medical administration records. I think we meant the medication administration records, the MARS. That's the part of the 1,000 or so page document that lists all the medication she would have received. Is that correct?
Yeah, that's what a MAR is, that's correct.
All right. And when you wrote your summary, just so we're very clear, you did not turn to the back there to see what the ICU doctor that evening dosed her with during her palliative extubation. Is that right?
No, no, I would not have.
As far as the amount of fentanyl and/or midazolam?
That's correct. Yeah, I would not have reviewed that.
All right. And following up on what the said on cross, do you assume good intentions in those you work with?
Yes,
With the doctors,
yes,
with the nurses,
yes,
with everyone?
yes.
When writing your discharge summary and signing that death certificate, were you assuming good intentions of everyone you worked with?
Yes,
Thank you, I have nothing further.
yes.
Okay, thank you, doctor. We're going to shut you down. Appreciate
Thank
you.
you. Thank you.
Okay. Are we ready to bring back the other witness?
I think we are, yes, Your Honor.
This young man will lead you up. Right there.
I'm sorry. Oh, Dave.
I was being nice, he's younger than me. Grayer, but younger. Okay, ma'am, you're still under oath? Go ahead and get yourself comfortable. Remember, speak loudly. Mr. Baez.
Thank you, Your Honor. Good afternoon, ma'am.
Okay,
Speed round is over, okay?
right?
All right. I wanted to backtrack for a little
So you're
bit.
done? You said it was over.
I said speed round was over, Judge. So I wanted to backtrack just a bit, so since we're not in a rush, to kind of bring us up to speed on some things. Now, Miss McDonald had ovarian cancer, correct?
Correct, stage 4.
And that's out of how many stages?
4.
Okay, so she was pretty sick to begin with.
Correct, it had spread into her lymph nodes and into her liver.
Okay, and that's when she was directed to come to the hospital because of her elevated liver enzymes, correct?
Correct, they felt that it was from the clinical trial that she was on, those medications that she was on.
Okay, and then subsequent to that, her conditions just seemed to get worse and worse, is that correct?
Yes, after she was there for a couple of days, her liver enzymes just kept getting worse, and then she became more and more acidotic.
Let me stop you there.
Sorry.
When you say acidotic, are you referring to her lactic acidosis?
I'm referring to her pH and her lactic acidosis.
Okay, we're gonna go into that in just a second. Talking about pH first. Are you familiar with the scale, the pH scale, and what's considered sustainable with life and what's not?
In some sense,
Okay. And you're aware that she was at a 6.9,
yeah,
correct?
she was 6.8, 6.9, which is usually not sustainable with life.
Okay. That, and normal should be around 7.4, correct?
Correct.
So she's at that very end of the scale before someone passes away.
Right, and your organs do not like that. They will shut down when you are that acidotic.
And she already has issues with cancer in her organs, correct?
Correct.
Specifically her liver, that it moved over to that area,
Correct.
correct? And then she also suffered a pulmonary embolism, correct?
Oh, yes, that's what the CAT scan found. When they had sent her to the CAT scan that night, they found that she had blood clots in her lungs.
And that would make it difficult for one to breathe.
Correct.
And would that also create or could contribute to a death rattle?
I mean, it could, yes.
Okay. Now, let's talk about her lactic acid. That was at a 27.
Yes, very, very high.
And when you say very, very high, that's because normal should be at 1.
Correct.
And it is considered deadly if you're at 10.
Correct.
But she was at a 27.
Yes, and that was the highest I've ever seen on any of my patients.
Okay. Now, she also was attempting dialysis, correct?
Yes, so the nephrologist had come to see her. They were a little worried, from what I could tell from the notes, that maybe the metformin that she took for her diabetes was causing her to be so acidotic. So they were trying to dialyze her to get any of that extra out. I think the nephrologist's note had said something along the lines of, basically, we have to try, because she was so young, they have to try to see if that's what it was.
And you testified under direct examination that the doctor on the floor had noticed that she needed to be intubated, so called over to the ICU to see if they might be able to see her sooner.
No, he came. The floor doctor came to the ICU and talked to Dr. Husel, because normally you would have to, normally there's a time frame, right? Like you would have to put in orders, and you would have to get a bed, and you would have to get report, and it would take some time to do. So he came and he was talking to Dr. Husel and was telling him how sick she was. And Dr. Husel was like, just bring her now, we will take care of her. So he, in essence, saved her life at that point, because he was like, bring her now, we'll take care of her, and he did. He intubated her within like 2 minutes.
Okay. So, and of course, the person who did the emergency intubation was Dr. Husel.
Correct.
And her condition continued to worsen, is that correct?
Correct. Throughout the day, it got worse and
Now,
worse.
I'd like to take you to the situation when finally a conversation was had with the family. Prior to Dr. Husel and yourself speaking with the family, other doctors had advised her of her condition, correct?
Correct. They had spoken with the family. It looked like multiple doctors had spoken with the family about how sick she was.
And all of them had discussed the potential that Ms. McDonald might pass.
Yes.
And now I'd like to discuss with you the conversation that you had with the family. Did you request for Dr. Husel to come and speak with the family at a certain point?
I let Dr. Husel know about her lab work and what her last blood pressures were, basically letting him know that she's not getting any better, she's getting worse. And he, from my notes, it said that he was calling the family, or the family might have been in the waiting room. I don't remember. So we both spoke with the family after they came in.
Now, what was Dr. Husel's demeanor when he spoke with the family?
I mean, very caring. He's an amazing doctor. So, I mean, he was definitely very caring with him. He discussed with them different options, whether or not they wanted to keep her as a DNR CCA, and we would continue to do the same things that we were doing, or did they want to go ahead and...
Defendant's statements are coming?
It's not hearsay.
They.
Let's go sidebar on this one since you said words. Ladies and gentlemen, let's get busy. You're in the final stretch.
So I have my own bathroom, my own cocktails, my own popcorn. Oh, you don't have my popcorn. Big truffle popcorn.
Okay. Ladies and gentlemen of the jury, you're to strike the last question and answer, disregard it. New question.
I just want you to tell me Dr. Husel's demeanor, not what he
Oh,
said.
the whole thing, okay, so sorry. He was very caring, was his demeanor.
The conversation that you and Dr. Husel had with the family, was it a thorough conversation?
I believe so.
Okay. Did you convey to the family all of the options that they had available?
I didn't, Dr. Husel did. Yep.
Sustained.
If Dr. Husel had not given them all of the options, do you, in your custom and practice, would you fill in the blanks, for lack of a better phrase?
I would have discussed different options with the family, just so they had an idea of what we were looking at.
But you didn't find it necessary to do so in Brandy McDonald's case, correct?
No, they had already decided code status before I had gotten there, and then,
But the conversation that the two of you had with the family, you didn't find it necessary to add to anything
no,
that wasn't conveyed to the family?
correct, no.
Okay. All right. And then you mentioned under direct examination that you verified the dose amounts with two different nurses. Is that correct?
I verified the dose amount with with my charge nurse.
Let me stop you there. Which is a supervisor of sorts, correct?
Correct.
Okay. And go ahead.
I don't remember my whole conversation with the other nurse at the Pyxis, but obviously he knew how much I was giving because he went and got me a bigger syringe.
Okay. And at no time did either one of those individuals stop you from...
Finish your question.
At no time did either one of those individuals stop you from administering the dose or pose any issues with it?
Now you're going to compound on me.
Okay, I'll just stop.
Sustained.
Okay. At no time did either one of those nurses stop you?
No, correct.
And at no time did either one of those nurses convey any displeasure or questions about the dose?
Correct.
Now, another factor, there are numerous factors that go into, strike that. The other thing that I'd like to point out is Miss McDonald, her weight was listed at 273 pounds, correct?
I think she, in the end, when she came to the unit, she was 131 kilograms, so I thought that was closer to 280 something, but around there, yes.
Okay. Close to 300 pounds.
Correct.
Okay. And her BMI was 40?
If that's what the chart says, I don't know how to do that in my head.
Okay. Now, that is relevant in a dose amount, is it not?
Correct.
Okay. And that is because fentanyl likes the extra weight, is it not?
I don't know.
Okay,
I'll
she
withdraw.
doesn't know. Do you still want the objection?
I'll withdraw the question, Judge. Now, where we were earlier, I want to go back briefly to where we were earlier. Do you recall we were able to establish that the vent was set at 34?
Correct.
Okay. I'm now going to show you again Joint Exhibit 5, page 286 to 287. Do you see that?
Correct.
And the vent was set at 34.
You just went through this the first session.
Yes, I'm going back to finish my point, Judge.
Okay, well, let's go to your point then.
Yes. And that was at 11:40 in the morning, correct?
Correct.
Now, this only charts from 6:36 PM, and we discussed her breathing over the vent, correct?
Correct.
And the palliative withdrawal. Now, just before the palliative withdrawal, she was at a 30. Do you see that?
This is around, because when I can tell from the other charting what the saturations were, that when I pulled the vitals over at 2131 or 2130, that I had already extubated her. So that 30 is most likely right after I had extubated her.
Okay, so she was breathing over the vent initially, correct? And what
Oh, wait a
time do you have the
minute. No,
extubation
I'm so
at?
sorry, extubation is 21:51. I don't know why she was breathing at 30.
Yeah, that's what I was, that's,
Wait a minute, I don't know.
that's what I was getting at. So she went from over-breathing for multiple hours, let me see, that's 4 hours approximately, correct? Mm-hmm. And you have to say yes for the court.
Oh, sorry, yes.
Okay, and then before the extubation, I guess what is that, 20 minutes beforehand, 21 minutes beforehand, she was breathing at 30, correct?
Correct.
She's not breathing over the vent anymore.
No.
Fair to say she's tiring out at that time, or that's what the records indicate.
Sustained.
The records indicate her breathing went down,
Correct.
okay? And then after being extubated, she's at a 19.
Correct, and then she was at a 20.
And then
so-
5 minutes or 4 minutes later, she goes up to a 20, correct?
So obviously, the fentanyl didn't affect her respiratory
Okay,
rate.
sustained, there's no question.
Is there
pending.
any?
Sorry.
I'll rephrase it, or I'll ask this way. Was there anything to indicate to you that the fentanyl in the records indicated, affected her respiratory rate?
No.
Sustained, disregard, ladies and gentlemen.
As part of your job, you were to monitor a person who's taken off a vent as to how they react. Is it not part of your custom and practice?
Yes.
Okay. And that's also why you chart a lot of this information, correct?
Correct.
So this is your job to make, and one of the things you look for are the reactions to medications, correct?
Correct.
In fact, that is part of your job, that you have to see if there are any adverse reactions to medications.
Correct.
So in this situation, you did not note or did not see any adverse reactions to,
Sustained.
is there
Want a
anything?
sidebar?
If you insist, but
Well,
I'm trying to get around it.
you can't, though, the way
Okay,
you're going at it.
then I would like a sidebar.
Okay. How you guys doing? We're gonna go sidebar. I don't know where David's at. He's back behind me. I can see him in the corner of my eye. You just been so efficient today. Tell me when you're ready. Ladies and gentlemen, we disregard the last question and answer. Next question.
My last question on that topic is there anything in the records to indicate to you that she had an adverse reaction to the medication?
No.
Sustain.
I thought that was what we agreed upon.
No.
All right, I'll move on.
If she saw any adverse reactions, that's what we agreed to.
I'm sorry?
If she saw any adverse reactions, that's what we agreed to.
I've moved to strike the last answer as well.
We'll strike the last answer. You want to ask the question this time?
Yes, sir. I apologize for the misunderstanding. Did you see any adverse reaction to the medication?
Objection.
Sustain.
I'm sorry, Judge.
Did you see any adverse reaction?
No.
Next question.
Okay. Thank you, Judge. Now, you mentioned that in direct examination that the purpose of giving the pain meds was to prevent Ms. McDonald from suffocating to death. Is that correct?
From feeling herself suffocate to death.
I'm sorry, can you say that again?
From feeling herself suffocate to death.
Okay. And that was your intent when you administered this medication, correct?
My intent was that she would not feel herself suffocate to death when I removed her from the ventilator.
You did not intend on harming her in any way, shape, or form, did you?
No, I didn't.
Okay. And that was always your intent?
Correct.
And you never conspired or agreed with Dr. Husel to...
Sustain. Let's rephrase it.
I just want to ask that was your sole intention, to make her comfortable in comfort care?
Correct. That was, yes.
I have no further questions. Thank you, Judge.
Redirect.
Just briefly. On State's Exhibit 5G, defense counsel asked you, you had entered that note correctly. What time did you enter the note, if you recall?
It should be when I entered the order itself, which I believe is 2131.
Is that the 012, does that correspond with the pain score right here?
Yes,
And what time is that?
2151.
And was that before or after you had removed the medication from the Pyxis machine?
That was after, but it was the order that I wrote. Like if you go to medication orders, the ones that I actually wrote, you'll see where I have that on there.
Can you say whether or not the pharmacist actually saw the
They
notes
should
that you
have
entered?
if they were doing their job.
Okay, so you can't say?
No, I can't.
That was argumentative. You can't do
Sorry.
that.
Sorry.
Okay? You can only tell us what you know, what you see, what you observe through your senses.
Going back to this page that defense counsel showed you, is it fair to say that her respiratory rate was going up and down continuously over this time period?
With,
Objection leading.
I'll permit it.
while she was on the ventilator? Is that what you're asking?
Yes, over this time period shown here.
It was, her respiratory rate was elevated.
But it was
That's not what you're
going,
asking.
so it started at 39, did it then go down at any point?
Yeah, so it went down to 36 and then back up to 38, 35, 32, so
And then did it go back up again?
32, 37,
And then
Yes.
did it go back down again?
yes.
Is that, can you say if that's correlated or not to what was going on, how you're talking about her overbreathing and tiring out?
Yes,
The ups and downs, can you
The
explain that a little bit?
So the 38, the 36, all of those, so she's over-breathing the vent at that time, showing some distress. Like I charted, she was guppy breathing, so she was over the vent. I'm not sure, could you ask the question again? I think I got lost.
I think you explained it well, thank you. At any point while that was going on, did anyone from her family approach you with concerns about her breathing?
I don't remember.
Did anyone from her family approach you to say that she appeared to be in pain?
I don't remember.
Had you treated her for pain at any point on your shift that night prior to the 1,000 micrograms?
I don't know.
Showing you the medication administration from that night, States Exhibit 5H.
You're getting outside the scope, aren't you?
I'm going to pull it back in, actually, right here.
Okay.
Defense counsel asked you about factors that you need to consider when dosing. Is that correct? Do you remember that?
Objection, Judge. I just asked her about a weight.
Let's rephrase the question.
Did the defense counsel ask you about any of the factors relevant that you must consider when dosing medication?
I don't dose medication.
When considering, is it your job to consider whether a doctor's dose is appropriate or not before you administer it?
Yes.
And what factors would you consider in that process?
Could be a lot of different things. Could be weight, what sort of medication she's on, or he or she is on, everything that's going on with the patient.
And do you recall testifying about her weight earlier?
Yes.
Would one of the things that you would have considered have been the fact that earlier in the evening she had received a 50 microgram dose of fentanyl and that the medication records indicated it was relieved, that her pain was relieved?
I don't remember knowing that she had received that or not.
Would that have been an appropriate factor to consider?
Objection. On the scope.
I would agree, sustained.
No further questions?
Thank you, you may step down. I would go for another witness, but it's 8 till. You guys had enough of me today? Ladies and gentlemen, have a wonderful evening. We'll get started at 9 tomorrow.
All rise.
Remember the admonition? Let's get started promptly at 9, folks. Have a great evening. I don't know what it looks like outside, but hopefully it's nice.
Real nice.
I won't get to enjoy it, but that's okay. The seniority here.
Thank you, Your Honor. This has nothing to do with today's proceedings, but it does have to do with our expert, Dr. Schweiger, who is contemplating coming in midday next Monday. And I haven't got all the times yet. And then staying again overnight and being available most of the day Tuesday. So I just wanted to find out if the court thinks that staying a little past 5 with somebody coming in from Tampa on the one day to make sure we get him all done on the second day would be possible. I just wanted to, we obviously are trying to juggle the flights, and I'm just throwing it out there to see if you have any thoughts on that.
Do we know approximately what time he's coming in Monday?
I'm trying to get that information now. I think they're contemplating him coming in the morning and being available for examination here in the afternoon, and then finishing testimony the next day.
Did he review all 14 of the records?
He did. He did.
How long do you want to go past 5? Because the best thing I can do with the jury is, I need a favor from you.
Yeah,
Can we go a little past 5 on Monday?
yeah, I'm sure.
You know? But when we say a little, you know, half an hour is what you're talking about, an hour?
Yeah, probably no later than 6. Not this type of testimony. I mean, you know, it's a lot.
It's a grind on them.
Yes, it is, I agree.
Are we better off just to get him started earlier, if he can get in?
I'll work with them to the best of my ability. I just don't want to be in a situation where he's looking at a 3rd day.
Well, the question becomes, is what do we do on day 2?
Yeah, I know.
Are you leading this exam?
I am.
Okay. Estimate